Good morning, Brazil. Good night, Australia. Before anything else, I'd like to say that this session of the event will be happening especially in English. But if you switch language, you can go to the other room, which the link will be on the description. This other room has simultaneous translators, which will translate the event in Portuguese and English. In this room, we'll be speaking in English during the sleep and obstructive sleep apnea session. Antes de mais nada, gostaria de dizer que essa sessão do evento acontecerá principalmente em inglês, mas se mudarmos de idioma, você pode ir para outra sala, cujo link está na descrição. Essa outra sala conta com tradutores simultâneos que farão as traduções do evento para o português e inglês. Nessa sala estaremos falando em inglês durante a sessão de sono e apneia obstrutiva do sono. Well, so I'd like to welcome each one of you for the first Brazilian and International Medical Schools Association Conference. I'd like to thank Faculdade de Minas, Faminas BH, a Brazilian college, which is our principal supporter on this event. And I would like to thank UniBH, which is represented here by Marconi. They are really supporting our event and helping us through everything. So Marconi, would you like to say anything?
Good morning, everyone. It's a big pleasure to be here with you and discuss a little bit about pediatric pulmonology. That is my passion. And I'm sure that you will enjoy this event a lot because we prepared everything so with a lot of emotion, and it's a big pleasure to be here to open this event and to say hello to everyone.
Now, I would also like to thank the International Federation of Medical Students Association for bringing all the organizers together to elaborate this event. We have people from all around Brazil, and we have some people from Australia too. So thank you very much for this. So this event will be happening during 2 days, today and tomorrow, during the morning. Today, we'll have speakers from Australia and Brazil approaching sleep and obstructive sleep apnea and asthma. Tomorrow, our speaker will be approaching pneumonia and radiology. We also have an extra session about residents in Australia and Brazil with speakers from Australia and Brazil. Able to record her lecture and send it to us. So her presentation is about anatomy of childhood sleep obstruction. Dr. Miller is an Australian leading ear, nose, throat specialist and lecturer at UNSY. She specializes in the management of both pediatric and adult ear, nose, and throat disorders. And she is the only female ENT surgeon representing Southeast Sydney Area Health Service. Thank you very much, Justin. I'm sorry, but they had a problem with the transmission of the video, so we'll be putting it in just 2 minutes. Please wait there.
Hi, my name is Justine Miller. I'm an ENT surgeon working in the south of Sydney, and today I'm going to be speaking about the anatomy of childhood sleep obstruction. So I just wanted to talk a little bit about the anatomy in terms of dividing it into different sections. So essentially, the upper airway anatomy can be divided into the nose, the palate, the base of the tongue, the larynx, and then the subglottis and trachea. And if you have a look at this image here, this is a picture of a supine patient. And essentially, when we breathe in, the air goes through our nose, past the turbinate, past the postnasal space, past the palate, past the base of the tongue. Hi, my name is Justine Miller. I'm an ENT surgeon working in the south of Sydney, and today I'm going to be speaking about the anatomy of childhood sleep obstruction. So I just wanted to talk a little bit about the anatomy in terms of dividing it into different sections. So essentially, the upper airway anatomy can be divided into the nose, the palate, the base of the tongue, the larynx, and then the subglottis and trachea. And if you have a look at this image here, this is a picture of a supine patient. And essentially, when we breathe in, the air goes through our nose, past the turbinate, past the postnasal space, past the palate, past the base of the tongue, and then into the glottis and then into the trachea. And you can see in this picture here, there is just a continuous airflow through. In patients with obstructive sleep apnea, it can be obstructed at any point along this pathway. In this picture, it's showing at the level of the palate and at the level of the base of the tongue, so that airflow, rather than going down and then into the airway, is getting stuck and coming back up. And that's depriving the patient of oxygen and will eventually cause them to wake up. It's really important in terms of the airway to understand that a child's airway is significantly different to an adult's. In a child, the tongue is larger in proportion to the mouth. The epiglottis is floppier and U-shaped. The vocal cords slant upwards. The cricoid is the narrowest part of a child's airway, and the larynx is more anterior and superior in a child. The trachea is narrow and less rigid in a child, and the lungs have less capacity in a child. So you can see here again, it's in this image that the cricoid is the narrowest part of a child's airway. The other thing I wanted to show is that the pharynx is a lot smaller in a child, particularly in this area here where the tonsils sit. So I just wanted to show you a video of the normal anatomy of a child. So you can see here, this is the turbinate on the left-hand side, and this is the septum, the midline partition of the nose. This is the base or the floor of the nose, and it may be a little bit narrow, but not too bad. This is a pretty normal anatomy. This is the eustachian cushion and the adenoids, and you can see they're not obstructing the postnasal space significantly. There's the soft palate. These are the tonsils, the epiglottis, arytenoids, and vocal cords. So whenever we're talking about obstruction, we're sort of looking at where it is along that pathway as to what is causing the issue. So I just want to go through how you would examine a child's upper airway. And with any examination in the body, we always start off with general appearance. So you're looking for failure to thrive, obesity, hyperactivity, open mouth breathing posture, whether they're syndromic or have any craniofacial abnormalities. Then I want you to look at the eyes, and you're looking for evidence of allergic shyness, as seen in this picture here. Denny-Morgan lines, which are these allergic type lines that patients can get underneath their eyes, a sign of allergic rhinitis. Allergic lashes, which are these sort of fine, wispy, long lashes, and conjunctival injection or erythema, as you can see here in this picture. The other thing that you're looking for is a supra-tip crease, which is often seen in patients that have bad allergic rhinitis. And that comes about from this thing called an allergic salute, where they're constantly rubbing their nose because of the allergy. This is a picture of images of two kids with what we call adenoid facies. And with adenoid facies, essentially they get a long, thin face with mid-face hypoplasia. They get crowded teeth and a high arch palate. They get an overbite, they get narrow maxillary arch, and they get open mouth breathing posture. So that's basically it from a general inspection point of view. Next, we move on to the nose. And so looking at the normal anatomy of the nose, we look for the turbinates, the septum, the choana, which is the space at the back of the nose, and then the postnasal space, or where the adenoids are. The most common causes of obstruction in children are turbinate hypertrophy and adenoid hypertrophy. So you can see in this picture here, you've got a significantly congested turbinate, and in this picture here, you've got very large adenoids obstructing postnasal space in this nase endoscopic view. So if we look at the lateral airway image, we can see here that airflow goes through the nostril, past the inferior turbinate to the postnasal space, and then past the palate. So in the nose, the areas of possible obstruction can be at the level of the turbinate or the level of the postnasal space, most commonly. This is an anterior view, and you can see here, here's the midline partition of the nasal septum. These are the turbinates again, and really the inferior turbinates it sort of plays the major role in terms of obstruction of the nose. You look at the septum, and in this picture here, you can see deviated nasal septum, which can also potentially cause nasal obstruction. Look at the turbinate. So this is an image of turbinate hypertrophy. So if you're not quite sure what that means, so this is a picture on the left-hand side of a normal nasal cavity. So you can see here, there's the septum, there's the inferior turbinate, and you've got plenty of space there between the septum and the turbinate. In this picture here, however, this is a picture of a patient with allergic rhinitis. You can see the septum here, and there's very little room between the septum and the enlarged turbinate. So that's what we call turbinate hypertrophy. Don't forget that the sinuses develop throughout childhood. So a 1-year-old will only have very small sinuses versus a 12-year-old where they'll be significantly bigger. When you look into the nose, look for allergic type mucin, which is classic for allergic rhinitis, and that's that really sticky kind of, it's almost like an elastic band type mucin. Nasal polyps, really uncommon in children. If you see polyps, suspect cystic fibrosis or primary ciliary dyskinesia. So we won't go into that any further. This is a picture of something called choanal atresia. So this is actually looking up from behind the nose. And you can see in this picture, it's a bilateral choanal atresia, and this one is a unilateral. So you can see the turbinate on this image. So what are we talking about? Basically, choanal atresia is where there is nasal airway obstruction, and it can be bony or membranous. So this here is a picture, a CT scan of choanal atresia, and you can see here that the nose is blocked. Adenoid hypertrophy. So this is a lateral airways X-ray showing adenoid hypertrophy, and you can see here, if you look at the airflow and this big mass here in this postnasal space, obstructing the airflow. And the critical area that we're looking for is actually between the palate and the adenoids. And this again is the nase endoscopic view of that big adenoid tissue. Very occasionally we see rare things such as nasal meningoceles in this, you can see in this patient. So just be mindful that sometimes it could be something else rather than just adenoid hypertrophy or turbinate hypertrophy. Moving on to the palate and the throat. So looking at the normal anatomy of the palate and the tonsils. So we move on to our oral examination. And we're looking here at a high arch palate. So you can see here, very, very high arch palate. This is in a child that has adenoid hypertrophy. And then you look at the tonsils, and you can see here, these are really huge, big tonsils. The tonsils are graded from grade 0 to 4. 0 is previous tonsillectomy, 1 is tonsils not obviously visible, 2 is within the pillars, 3 is beyond the tonsillar pillars, and 4 is touching in the midline. Don't forget there are a couple of acute infections that may be causing airway obstruction, acute tonsillitis, so bacterial tonsillitis, scarlet fever, so strep throat, viral tonsillitis, and quinsy, which is pus around the tonsil, may potentially be causing some airway obstruction. These are all acute conditions, and once they resolve, you would expect the sleep apnea symptoms to resolve. Moving on to the base of the tongue. So looking at the normal anatomy of the tongue, follicular and lingual tonsils. So if we have a look at this lateral airways X-ray again, or lateral airways image, we can see here, this is the base of the tongue that we're talking about, the lingual tonsils. And so it's this area that can become obstructed, particularly in kids with Down syndrome and other syndromic kids that have very large tongue face. This is a molecular cyst. So this is an image of a cyst, and this can actually cause obstruction of the airway as well, because, and this is another image very similar to that, because it pushes the epiglottis back and actually obstructs the airway. This is actually the child, and you can see here they've got a bit of intercostal recession, subcostal recession, really struggling to breathe because of the airway obstruction related to the molecular cyst. So in terms of the larynx, looking at the normal anatomy of the larynx, so we look at the epiglottis, the arytenoids, vocal folds, and the subglottis. So just wanted to show a little image of a child with laryngomalacia, and you can see here that they've got inspiratory stridor. Okay. And this is the scope of that child, so you can see laryngomalacia, so the arytenoids are flopping into the airway, the epiglottis is sigmoid shaped, and the aryepiglottic folds are foreshortened. This is an image of subglottic stenosis. So these are the vocal cords here, interarytenoid mucosa, and below the level of the vocal cords, you can see that there is this narrowing here. Just to summarize the anatomy, so essentially with the anatomy, it's really important that you look at where you think the level of obstruction is going to be. It's important to examine the child with general examination, look at the nose, look at the throat, and then if you have the ability to, look at the voice box and base of tongue with the nase endoscope. The most common areas of obstruction in children are at the level of the turbinate, so turbinate hypertrophy secondary to allergic rhinitis, or at the level of the palate related to the tonsils and adenoids. So adenotonsillar hypertrophy usually is either due to exposure to viruses and bacteria, or related to a biofilm living within that tonsillar and adenoid tissue, causing hypertrophy of that tissue. So two separate issues. So really, if you speak to, and just this can often be gained on just from the history, if it sounds like they've got allergies, or if they've had lots of tonsillitis or things like that, then you sort of, it's very likely that it's either going to be the tonsils or the turbinates. All right, I just wanted to go through a case history of a child with sleep apnea. The parents present with their 3-year-old boy who has difficulty sleeping. So differential diagnoses for this include obstructive sleep apnea, reflux constipation, allergic rhinitis, iron deficiency, sleep disorder. So from the history, I want to know if the child snores. Is it loud or soft? Does he have difficulty going off to sleep, or does he wake throughout the night? Is he restless? Is he sweaty? Does he have apneas or pauses in breathing? Any enuresis, open mouth breathing and neck extension, teeth grinding, difficulty concentrating, irritable, hyperactive during the day? I want to know the onset. So how long has this been going on for? For example, if they have an episode of acute tonsillitis, they might have really bad symptoms for that week, and as it resolves, things get better. Obviously, that's treated differently to a child that's had symptoms for 6 months. I want to know if the child is a full-term baby. Did they spend any time in NICU? A history of reflux. Does the child drink a lot of milk or iron? Do they have iron deficiency? History of allergic rhinitis, history of recurrent tonsillitis. In this child's history, the parents report loud snoring, nighttime sweatiness, unusual sleep positions, enuresis, daytime mouth breathing, constant nasal obstruction, and hyponasal speech. The parents also report that he is small for his age, he seems to eat well, but really struggles to put on weight. At daycare, they're concerned about his behaviour during the day. He can get quite irritable and throw tantrums easily. He lacks the ability to concentrate and has had 2 episodes of tonsillitis in the last 12 months. His background was normal birth, average developmental milestones, no other medical problems, vaccinations are up to date, and mum had her tonsils out as a child. So then we move on to our examination, just like before. So you general inspection, examination of the eyes, examination of the nose, oral examination, look at the chest for recession. So just like we discussed before, I'm looking for failure to thrive, obesity, hyperactivity, open mouth posture. I'm looking for the adenoid facies, which we discussed before. I look at their tonsils. Excuse me. Excuse me. This child's examination, he appears to have a thin and small frame. He's 5th percentile. He has dark circles under his eyes. His mouth breathing at rest. He has large tonsils. There's no evidence of any tracheal tug. There's no subcostal recession at rest. Investigations, I want to do a lateral airways x-ray to look at his adenoids, nasendoscopy if available, and sleep study. And so this is again that picture that I showed you before of adenoid hypertrophy, and then referral to a sleep study, and I'm sure the sleep physicians will go into this a little bit more, but basically the advantages of the sleep study is to confirm the presence of obstructive events, avoid surgery if the child doesn't have obstructive events, defines the severity of sleep disordered breathing to assist with preoperative planning, and provide a baseline for comparison after surgery. So why do we perform tonsillectomy? Basically, the majority of cases is for sleep apnea, and we treat obstructive sleep apnea with adenotonsillectomy. There's evidence of a 79% normalisation of PSA in the CHAT study, which was the Childhood Adenotonsillectomy Trial, randomised controlled trial in 2013. And we also take out tonsils for recurrent tonsillitis, and they're the two most common reasons. We also do them for quinsy or suspected neoplasm, to treat unusual infections, for tonsillitis or halitosis, for recurrent tonsillar hemorrhage, or access for other procedures. Tonsillectomy versus tonsillotomy. So tonsillotomy may permit more rapid recovery than traditional tonsillectomy for patients with OSA, but is associated with a greater risk of regrowth, which may require revision surgery. So 73% of surgeons perform tonsillectomy over tonsillotomy on a survey of 300 ENT surgeons in USA. So generally in Australia, the majority is probably very similar. The majority of surgeons will perform a tonsillectomy over tonsillotomy. I personally perform a tonsillectomy over a tonsillotomy. How do we do it? Basically, it's done under a general anaesthetic, usually with a ray tube, but can also be done with a flexi LNA. The patient's placed in the rose position, which is the head extended and a shoulder roll, and they have a Boyle-Davis gag. This is just showing you that image of the patient having a tonsillectomy. It can be performed with diathermy, cold steel, cold ablation, harmonic scalpel, laser, or guillotine. And these are just showing you some of these images. So cold ablation here, diathermy in this picture. I personally do diathermy. I did do cold ablation for a while, but I've switched back to diathermy. Adenoidectomy is often performed in conjunction with tonsillectomy, and we perform it with either suction diathermy, cold ablation, or curette. I personally do it with cold ablation. Now, really important to understand complications of tonsillectomy. So intraoperative complications include dental injury, pharyngeal injury, lip or tongue burn, commissure abrasions, bleeding, and airway fires. Early complications include primary hemorrhage, which is less than 24 hours from the time of surgery, post-obstructive pulmonary edema, airway obstruction, aspiration, laryngospasm, pain, and dehydration. Late complications include secondary hemorrhage, infection, Greisel syndrome related to the adenoidectomy, voice change and VPI in 1 in 5,000 patients, nasopharyngeal stenosis, and taste disorders. Post-tonsillectomy hemorrhage is seen in about 2 to 3% of patients, can occur up to 2 weeks after tonsillectomy. 1 in 10 patients that present to emergency need to go to the operating theatre. So things that can go wrong during a post-tonsillectomy hemorrhage, basically, like with any emergency, just remember ABC. So we start off with the airway. Securing the airway is the most important part of the operation, and blood in the airway can obscure the anaesthetist's view of the airway. It can also cause laryngospasm. So if you can't get the airway in, there's another option to put an LMA in. If the airway can't be secured, then may need to start CPR. Laryngoscopy, bronchoscopy may be required, and really tracheostomy is reserved as a last resort. Breathing, aspiration of blood into the airway may affect the ability of the lung to function, and then circulation. Apply pressure to the bleeding site, which is quite challenging given that it's in the back of the throat. Ensure adequate resuscitation of blood is available. Suction is used to help identify bleeding site, and bleeding is controlled either by cauterization or with a tie. Once the bleeding is controlled, you can put in flow seal fibrillar Surgicel to the tonsillar fossa. The anterior and posterior pillars are often sutured together, and recovery is the same as recovery after a tonsillectomy. So in this case, there was evidence of OSA on the sleep study. The patient was not at high risk, the parents were keen to proceed, and therefore adenotonsillectomy was performed. Just wanted to very quickly talk about turbinate surgery. So turbinate surgery for children with turbinate hypertrophy is often done in conjunction with adenotonsillectomy if it looks like the turbinates are the area of obstruction as well. In kids under 10, I do something called a turbinate cautery with coablation. And so basically the little coablation needle is inserted into the turbinate, and then lesions are placed within the turbinate to help shrink it down. In kids older than 10, I generally do an endoscopic turbinoplasty, which essentially I do with microdebrider, and it's sort of removing that part of the turbinate so they can still function, but so it opens up that airway substantially. So in this case, after surgery, the symptoms significantly improve, and that's the talk that I've got for you today. So I think the key from my perspective in terms of the airway is looking for airway areas of obstruction, and we sort of in kids think either turbinate hypertrophy or adenotonsillar hypertrophy as the most common causes. There are other rare causes of sleep disorder, and therefore it's always important for an ENT surgeon to examine the airway to make sure that we're not missing anything else before we proceed with surgery. Thank you for having me.
So I'd like to thank Dr. Miller for sending her presentation to us. And if you have any questions, please send us by email and we will address them to her. Our next lecturer is Dr. David Lowinger, who will be addressing anatomy of adult sleep obstruction. Dr. Lowinger is a leading ear, nose, throat surgeon with expertise in ENT care for children and adults. He has been a long-staying VMO ENT surgeon at the Sydney Children's Hospital and St. Luke's Hospital with a private practice in Bondi Junction. So thank you very much, Dr. Lowinger, for being here with us. And please feel free to start your presentation.
Thank you. I'll just try to load it up.
Can you hear us?
I can hear you. Can you hear me? Yes. Can you hear me? Share.
Dr. David Lowinger?
Yep. I'm just trying to share the screen at the moment.
Oh, okay. You can click on share, please. Then share screen.
Yep.
Entire screen, and you please check the box share system audio on the left on the bottom.
Yep. On the bottom. Sorry, I don't have that box. Where is that? Share. Is that working? What about now?
I don't think so. Can try again, please?
All right. Share screen. Yep. Share screen.
Yeah.
Okay.
Share screen.
Choose what you want to share, it says.
Please share the entire screen, please. Just like click on it and then click on the box on the bottom on the left, which is written share system audio.
Click on the box.
And share.
Share.
Yeah, now click on share. Did it work?
Click on share. I don't know if it shared the audio. Where's talk? Yeah. Can you see the talk?
Sorry?
Can you see the talk? Can you see the?
Can you get a little bit closer to the computer so I can hear you better?
Sure. Can you see the talk? Can you see the PowerPoint? Times of permission to capture a screen. All these steps. Blah 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 blah.
Well, usually we just click on share, then share screen, entire screen, and then there is on the right, on the bottom, share box in blue, and we just click on it, and then it shares the screen.
Okay, let me just see this.
Okay.
Probably some Mac. I'll want this up. Let me just see if this works. Get that?
Well, would you like to mail me your presentation, and then I can just like
Yeah, sure. Let me just
share it here.
let me just give this a go once more, and if it, let's just see if this works now. I think it was a Mac problem.
Okay.
Share. Times of permission capture screen. Follow these steps. Privacy, put screen recording. Check
Well, I sent you my email on the private chat, so you can just like send it to me whenever you want.
I'll send it to you. I can try to get my computer expert down here in a second. He can
Sure.
do it too, but I'll email it to you. All right. I'll get that email and I'll send it to you. Sorry about that. I don't know. I think it's a Mac. Seems to be some sort of Mac problem.
Well, it's okay. It happens.
Yeah. All right. Let me just. Here we go. I've got my tech expert here. He's going to give it a go. This is Ethan.
Anyway, we are really excited for you being here, to be honest, and for your presentation. So it will be all worth it. So don't worry about it.
Share screen. Yeah.
And which window?
So maybe you get PowerPoint. Yeah. Do that.
Okay.
Okay.
So if it's the right PowerPoint,
Share.
share. Okay, wait. Yeah.
Okay. Just.
It's just yep. Okay.
Sorry, my talk will be 5 minutes shorter to make up for this.
Oh, you don't have to worry about it. I think Virginia can wait. Just kidding, Virginia.
Unless Virginia wants to go first and I'll go after her. That's another option and I'll just get this done.
Well, Virginia, are you there? Like, can you maybe we can do Virginia's presentation first, and then we can do yours. I don't know if you have anything after this. Would it be okay for you?
It's fine by me. Yeah. All right, I'll run this. Is that okay with Virginia, or do you want me to email it to you? I don't know what's wrong. All right. So, Jenny, what would you like? Would you like Virginia to go first, or do you want me to email it to you and do it that way? Hi, Virginia.
I'm here as well.
Hello.
Okay, so right, I think it's uploading the presentation.
Yeah, I'd love to do it off my computer. I just don't know, for some reason it's just not doing it for me. I'm not quite sure why.
Yes, it might be the app being
That's strange.
okay. All right, so share.
Unless you want to do yours and I'll go
Sorry.
for it, but either way.
Let's
Sorry about that.
Share, yeah, share screen. You might have a sound. Share screen. Okay. Share system audio. Entire screen is there. Click on this window. Share. Okay. Yeah. Am I sharing?
Yeah.
Yeah. Can you see that, everybody? Yeah. Juliana, is that okay?
Just now I saw you not hearing me. I'm sorry. I was mute. So yeah, you can start. So I'm just going
Can
to.
everybody?
Yes, they
Can everybody see the presentation there? Can you hear me?
Yeah. So I'm just going to do
Okay.
a brief presentation of who you are. So this is Virginia Oliveira. She'll be approaching childhood sleep disorders, and Dr. Oliveira is the founder and clinical director of the Sleep Cottage in Miranda and Southern Healthcare Specialist in Cornwall. She has postgraduate in training in the Children's Hospital at WISMAD and Sydney Children's Hospital, and continued to work at these hospitals for a period of 10 years. So thank you so much for being here with us, Virginia, and please feel free to start your presentation.
Bom dia, todo mundo. Eu sou Virginia Oliveira, sou brasileira, treinei em Belo Horizonte e é um prazer estar aqui apresentando para vocês. Então, eu vou apertar a tecla SAP e vou passar para o inglês, tá bom? Thank you for having me. So I'm going to talk a little bit about sleep studies and their indication and setup. So before talking about sleep studies, I think it's important to talk a little bit about what sleep is and what healthy sleep is. So having healthy sleep means having a good sleep routine, enough sleep, non-interrupted sleep. And sleep, in fact, is a combination of several cycles of alternating light sleep, deep sleep, and dream sleep. So, and the quantity of sleep and the amount of time we spend asleep varies from age. So a newborn baby from 0 to 2 months, for example, it would be sleeping for an average of 13 hours. And as we become older, we sleep for less. Adolescents should sleep for around 9 hours, and as an adult, we should aim to sleep at least 7 hours. So newborns have shorter sleep cycles, so they go from 45 minutes to 60 minutes. And they have a slightly different composition of the sleep cycle. We say the newborns have active sleep and quiet sleep, whereas older children have cycles between 60 to 90 minutes. And the cycles, again, just to rephrase, they're divided in light sleep, deep sleep, and REM sleep, which stands for rapid eye movement sleep. And that's when we dream. So after every cycle, we have a little arousal, a very short arousal, some movement, changing body position, and we start a cycle again. Just to illustrate how our sleep stages go, so from 1 to 5, it's a cycle of sleep. So it starts with non-REM sleep stage 1, and that's drowsiness. Non-REM 2 is light sleep. Non-REM 3 and 4 is deep sleep, and REM sleep is dream sleep. So in light sleep and deep sleep, we grow and we heal. So that's when growth hormone is produced and melatonin is produced. And in dream sleep, the last part of the sleep cycle, that's when we dream, when our day's events are organized and stored. That's when our brain is quite active, but our body rests because our body is paralyzed. And that's when problems with breathing happen, because if you imagine that the body is paralyzed, then if you have obstructive events, they become more problematic in REM sleep. So our babies spend, as we become older, the amount of or concentration of REM sleep decreases. So as an infant, as a baby, babies have around 50% of REM sleep. And as an adult, we have a quarter of our sleep, or 25% of our sleep is REM sleep. So just talking a little bit about the epidemiology of sleep disorders in children. So by around 3 years of age, a child spent more time sleeping than in all wakeful times combined. So if you imagine that a child sleeps for 12 hours a day, that is quite a significant amount of time spent asleep. And 25% of children experience some type of sleep problem during their childhood. And depending on which study you look at, between 7 and 30% of children in school age have snore. And we know that poor sleep in children presents differently from adults. So as an adult, when we are sleep deprived, we are sleepy and cranky, whereas children have irritability, a low frustration tolerance. They can have issues with learning, memory, and then a lot of behavioral difficulties. And sleep disorders in children look like ADHD or attention deficit and hyperactivity disorder. So, and interestingly, what we know, and I'll talk a little bit more about sleep studies and what they look like, is the behavioral disturbances in children do not depend, or they're not proportionate to the amount of obstructive apnea they have. So you can have a child with a mild obstructive apnea with severe symptoms, and a child with severe obstructive apnea with milder symptoms during the day. So when we talk about a sleep history, what are the questions that we can ask? So probably the most important sign of sleep problems and sleep breathing issues is snoring. It's important also to talk about how the child is progressing during the day, how the behavior is, because as Dr. Miller spoke about, the sleep apnea in children are quite significantly related to issues with big tonsils. Often the children have issues swallowing, recurrent tonsillitis, and otitis media. Kids that have sleep apnea, they grow poorly, they don't put on weight as well as we would like them to, because they spend a lot of energy sleeping, because they move a lot, they sweat a lot, they work hard to breathe, they have apneas. A lot of children with issues with obstructive sleep apnea and sleep disorders, they have issues with bedwetting. So they're delayed to be dry at night, and they also have teeth grinding or bruxism. So we can divide childhood sleep disorders in 3 types. So there's difficulties with onset of sleep, and that's mostly behavioral. So the most important from our point of view when we're talking about sleep studies is the sleep maintenance disorder or difficulties maintaining sleep, which means that the child wakes up several times a night, and that's often related to obstructive sleep apnea or periodic leg movements, which we'll probably talk in a different talk. So I guess if you don't take anything from this talk, one thing that I would really love you to take home as an important message is children should not snore. Snoring is not normal. Snoring is not normal in adults, but particularly in children. We do know that children, 90% of children do not snore, and a fifth of children who snore have obstructive sleep apnea in their sleep study. So it is very important that every children with snoring should have a sleep study. And the issue is that a lot of children, as you imagine, wouldn't be sleeping supervised, or they'll be sleeping in their own room. What that means is that often parents would, if a child is waking up, come into the parent's bed every single night, often they won't know if the child is snoring or not. So because they sleep in their own bed. So often we do request sleep studies if children are waking up often and we don't have a clear history of snoring, because often the parents don't know, and sometimes the snoring means obstructive apnea, sometimes the snoring means more severe presentation of sleep apnea. So what a sleep study is so a sleep study or polysomnography is a gold standard test for obstructive sleep apnea in children and adults. It's very important because, as we said before, snoring is a sign of sleep apnea, but we need to know how severe it is, because then that defines what type of treatment we need to recommend. We need to know if it's mild, moderate, or severe. And if it is severe, do we need to inform the ear, nose, and throat specialist. So in define what their perioperative risk is. Do we need to put this child on a CPAP machine before they have surgery? And just importantly, polysomnography is purely helpful for kids that we suspect have sleep apnea. And for behavioral difficulties, it's not indicated. So as I said before, every patient who snores, particularly children, should have a sleep study. So what a sleep study is an overnight stay in a sleep laboratory. And what we do is we set up with a full body gear. And just to talk a little bit about it in more detail, so we look at the brain waves through an EEG, and it is not a 12-lead EEG, but a partial EEG with 7 leads and 2 leads around the eyes. And the EEG is important so we know what phase of sleep the child is, either, as we said before, light sleep, deep sleep, or dream sleep, or if the child's awake. So there's also, so that's on the top here. The respiration or breathing is looked at from a nasal flow perspective. So I'll show you a couple of other pictures next. So there's a nasal cannula that goes under the nose, and that shows us how well the child's breathing through the nose. There is also what we call a nasal thermistor, which is an oral nasal flow. So it's a backup or a plan B option for when we're looking at breathing. We also look at oxygen saturation. So there's also a pulse oximeter that is attached to the child continuously. And for children's sleep studies is very important. We have a carbon dioxide reading, and that's done continuously overnight. So those bands here that you can see, the chest and abdominal bands, they tell me about the breathing effort and also increased worker breathing. There's also the microphone that stays on the bedside and that detects any breathing. And heart rate is also measured continuously, and also leg movement. So there's also probes that sit on the child's leg, or, you know, similarly in adults as well. So just to give you a bit more an idea of what it looks like, the setup. So on top here, you've got the head electrodes on the face. This electrode here shows me the eye movements, and under the nose there's the nasal prong. We don't obviously deliver oxygen, but we measure nasal flow. On the chin here, there's chin movement, and that helps us define what phase of sleep that child's in. In the next photo, there's the body setup. So just here is for each laboratory can choose a different sleep study system. So the system we use in our laboratory is called a NOx system. And the beauty of the NOx system is that the head box, or the part of the equipment that collects all the data, is very small and sits on the child's chest. And then you can see all the electrodes connect via the wire into that head box. And the head box communicates with our computers, and they can be monitored throughout the night in the laboratory. So when we look at a sleep study, what we are looking for in a nutshell is apneas. So what apneas are pauses in breathing. And pauses in breathing can be divided in three types of pauses. So we can have a central apnea, an obstructive apnea, and a mixed apnea. So a central apnea is when we have a pause in the oronasal flow and also the respiratory flow. And often what we see, to call it a central apnea, is a desaturation of 4%, 3 or more percent. Obstructive apnea is when we have no oronasal flow, but the respiratory effort is still there. And as you can imagine, that happens because you've got big tonsils and adenoids, so there's no flow through the nose, no flow through the mouth, but the chest is still moving. So that's and the abdomen still moving. So that's an obstructive event. And babies sometimes have what we call a mixed apnea. So it's a combination of a slowing in the breath, but also some chest movement. So I'll show you a couple of other slides that are a bit more clear in terms of those events. But just to give you an idea, Justine spoke a little bit about this. So obstructive sleep apnea syndrome is the main reason why we do sleep studies in children. And what it is a narrowing of the nasopharynx, oropharynx, or hypopharynx, and that can cause obstructive apnea syndrome in children all ages and also adults. It's very common, particularly in preschool children, and that's due to increased size in tonsils and adenoids. And adenotonsillectomy is the first line of treatment for these children. And we know the kids that have syndromes such as Robin sequence, Down syndrome, cerebral palsy, they are more prone to having obstructive sleep apnea and have sleep apnea that persists despite having surgery. So in terms of central apneas, so central apneas happen very commonly in young children. So for example, if a child is dreaming about having a swim and the breathing follows what the child is dreaming about, you have a cessation of breathing during sleep, and usually it can go from 10 to 20 seconds, and usually it will follow it's followed by an arousal or a 3% desaturation. In younger babies, and you might have had exposure to babies in the special care nursery, those events can be associated with bradycardia, sometimes not. So it can be quite normal in children. So just to go back a little bit, obstructive apnea is never ever normal in children. Children shouldn't have any obstructive events, but central events are expected and can happen. If they're happening too often, that can be a sign of an intracranial malformation, such as Arnold-Chiari malformation. And there's also some unusual or quite rare conditions, such as congenital central hypoventilation syndrome. And the reason why that happens in babies is because of immaturity of the breathing control and the chest wall mechanics that are quite immature. So babies can be more prone to having those central events. So just to touch a little bit on apnea of prematurity, when we do sleep studies in babies, we often see quite a lot of apneas, and the younger and the more premature the baby is, the more prolonged and more significant those apneas are. So this is a photo of the clinics and the links to the clinics, so you're welcome to have a look at them. So we've got a clinic in Wollongong, and that's we do studies in children and adults, and we've got a clinic in Miranda, and that's where we do studies purely for children. It's been a pleasure to I'm just trying to keep it concise, and if you have any questions, don't hesitate to ask and send me an email. And appreciate the opportunity of talking to you today. Juliana, I think you're muted.
Thank you. So thank you for your presentation. It was very clarifying. I was wondering if there are any books or courses that you can actually indicate for medical students for whom wants to learn more about sleep apnea in children.
So there's our usual, it's a funny thing because I remember when I was studying physiology in Brazil back in the day, there was actually a very interesting, very well summarized chapter of our physiology books, the usual physiology book. It gives a really nice overview of what sleep and sleep cycle is about. There's always also a book called what is it called? I can send you a little list of nice books. There's a book that was written by one of the pretty much founders of sleep medicine in Australia, and he wrote a lovely book that talks about the journey and the history of sleep medicine, but also talking a little bit about the physiology and treatments and problems in sleep. So I'll just need to have a look at the book, and I'll send you the name. Every year there is the International Pediatric Sleep Association conference that has it goes all over the world. It is extremely interesting. And the Australasian Sleep Association meeting that happens every October, and anybody can become a member and follow the webinars. There's a lot of webinars in their website. So Australian Sleep Association is a good source of information as well.
Oh, that's great. I'm going to look it up and probably be a member of the society soon. We have one more question.
Mm-hmm.
It's in Portuguese. Henk is asking qual a idade ideal para intervenção cirúrgica, se tem alguma faixa etária mais indicada.
Na verdade, Henrique, não existe uma faixa etária pré-determinada. Os otorrinos aqui na Austrália, eles preferem operar a partir de crianças acima de 10 quilos, simplesmente por causa do acesso cirúrgico ser mais fácil. Mas, na realidade, a gente vê pacientes sendo operados em qualquer idade. Nas mãos do Dr. Lowinger, que vai apresentar daqui a pouco, basicamente crianças de 8 meses, às vezes tem adenoides grandes ou amígdalas grandes e são operadas. Varia muito da habilidade do cirurgião, do conforto que o cirurgião tem de acesso à via aérea, mas, na realidade, crianças que têm obstrução do sono detectadas na polissonografia podem ser operadas, seja em qualquer idade.
Obrigada, Virginia. So now I just want to thank you again for being a part of this event, not only helping us to organize it, but also being here presenting for us today.
Thank you.
Okay, so our next lecturer is Dr. David Lowinger. He is going to be addressing the anatomy of adult sleep obstruction. Actually, I'm sorry. He's going to be addressing a practical approach to little airways in clinical practice. And he is a leading ear, nose, and throat surgeon with expertise in ENT care for children and adults. He has been a long-standing VMEO ENT surgeon at the Sydney Children's Hospital and St. Luke's Hospital with a private practice in Bondi Junction. So thank you so much, Dr. David Lowinger, for being here.
Thank you. Can you see me? Can you share this? Is screen sharing okay?
Yeah, okay.
All good?
All good.
Excellent. Well, thank you very much. Thank you, Virginia, for asking me to talk. It was a pleasure and great to talk to medical students. I have two medical student children myself, so if anyone want to reach out to some New South Wales or Australian or Sydney medical students, I'm sure you can find, particularly my son Josh Lowinger. If you Google or Facebook or whatever him, I'm sure I'll be happy to have a chat to you and hear what being a medical student's like in Australia. So having been medical students myself recently and of course my kids at the moment, I thought I'd just make this quite practical, and actually my talk ties in quite well with both the previous two talks that you've heard. So with Virginia's talk, which is an excellent explanation of sleep apnea and sleep studies, which are very important in kids, and just a practical approach of how I look at airways, both in adults and kids, and the approach that I take. So let's see whether this video sound works. You might be able to just hear it through the speaker. Can you hear that sound?
Yes, we can hear it. Yeah.
You can hear it? Excellent. Yeah. Okay, so let's keep it practical. So this is a 3-month-old boy who had a chronic nasal discharge, obstruction, snoring, poor nasal airflow, and quite a thick nasal mucus. So you can hear his breathing here. Look how he's working hard. He's breathing through his mouth, not breathing much at all through his nose. And he's got recession here. So he's pulling his tracheal tug, and he's got the intercostal recession here. So there's a child who's working very hard with his breathing. So let's just a quick summary of nasal obstruction, because in little babies with sleep apnea, often it's more a nasal obstruction problem or a laryngeal problem that causes their concern, rather than necessarily their tonsils or necessarily their adenoids. So little infants can have significant sleep disordered breathing issues as well. So the 3 questions that you need to ask when you're the resident doctor in a small country town in emergency looking after everybody, or if you're the doctor in general practice, is, do I need to worry? That's always the first thing. So in medicine, we always think, do we have to take this seriously or not? So the key things with little children who have breathing concerns are, is it an acute problem? Has it happened suddenly, or does it mean something's happening slowly? So if it's happened very suddenly, then you would take that much more seriously. Is it a severe problem or a mild problem? So severe would be like that child with the tug and recession and work of breathing? And is it having an impact on the three important things in babies, which is breathing, sleep, and feeding, and then in older kids' behavior? What are the red flag features? So in ear, nose, and throat surgery, the most common red flag would be if something is one-sided. So if a child or adult has a one-sided nasal obstruction, or one-sided blocked nose, one-sided runny nose, one-sided bleeding nose, you're always going to take that a little more seriously, because usually if something benign is happening, it'll happen on both sides. If you have a cold, both sides of your nose will be blocked. If you have an allergy, it'll make both sides of your nose run. So if it's a one-sided thing in ENT, always take it seriously. So whenever you see an ear, nose, and throat patient, think of that. One-sided hearing loss, one big tonsil, one-sided blocked nose. And then you need to think, so that's, do I need to worry or not? And so if they're the red flags, acute, severe, those concerns, then you're going to need to worry, and you need to take it very seriously and act quickly, as opposed to acting more slowly and using medical measures. The second thing to think about is it a structural concern or a reactive concern, or both? So what does that mean? So a structural concern is when there's an anatomical narrowing. So you've seen some nasal anatomy and airway anatomy. So is it a blockage, such as a deviated septum or a polyp or a big turbinate, or is it a reactive problem, such as the nasal lining swelling, where the anatomy is normal, but it's how the nasal lining is reacting? Or is it a combination of both? So one, do I need to worry? Two, is it structural or reactive? And the third thing to think about is the front of the nose or the back of the nose, or both? So the third question you ask is does the blockage seem to be in the front? So what can affect the front of your nose? In a child, a polyp, a careful seal, as you saw before, really a swollen turbinate because of allergy or infection, foreign body, very important, or a septal deviation, or is it a back of nose problem, such as a big adenoid or a postnasal polyp, postnasal tumor? So if you look at those three questions, do I need to worry when you see a child with nasal obstruction? Do I need to worry, is it structural, reactive, and is it front of nose or back of nose? That will really direct how you treat, investigate, or refer that patient. So they're the three things I think you should think about. So let's quickly talk about, do I need to worry? So the most important concern with a child's airway would be a foreign body. So a foreign body may be a witnessed event, or they may have a symptom of a foreign body, such as a one-sided obstruction, an acute onset obstruction where they were completely fine until they were playing with their 3-year-old sister, and then suddenly one side of the nose is blocked because their 3-year-old sister put a bead or peanut up the little baby brother's nose. Is it also something that's been there for a while but is getting worse? So one-sided nasal obstruction. And I don't know if any of you have ever had a relative or friend or seen a patient that has had a foreign body up their nose for a long time, but it really smells. So it forms, usually the body forms a crust around the foreign body. It gets infected, usually with staph, and it has a really offensive smell. So I've seen children who have come to see me because other children won't play with them in the playground. And the reason is because they've had a foreign body up their nose for 6 months. The most important one is a button battery. So a button battery up the nose is an emergency, because that can set up a current and burn through the nose and burn through the septum, just like a button battery can burn anywhere in the airway. So if you ever see or hear or think that somebody has a button battery, which are the small batteries used in hearing aids or some toys, in their nose, or a child has swallowed one or inhaled one, that's a critical medical emergency. What about, do I need to worry about tumours? So you can have children or adults with tumours in their nose. So again, you would look to see if it's a one-sided problem, fairly acute problem, or it was progressively getting worse, not improving. Do they have any facial change, such as a swelling of their face or over their cheek, an eye change, any lymphadenopathy, an associated ear problem, which would come from eustachian tube dysfunction, or unusual bleeding, which can happen with vascular tumours like a hemangioma. So always have tumours in the back of your mind. They're rare, but if they occur, you really want to be able to pick them up, and they're the features you look for. So what about our second question, structural or reactive, or both? So reactive concerns will be more associated with these symptoms of cough and itch and irritation. So they're the sorts of allergic reactive symptoms that you'd look for: sneezing, eye irritation, throat irritation. Whereas a structural concern may be a blockage without all of those associated symptoms. And of course, if it's both, it can have both. So what are your therapies for nasal concerns? So if you think that you're not worried and you think it's more reactive than structural, and you think it may be more front of nose and back of nose, you might try some saline sprays or antihistamines or decongestants, inhaled steroids, of course, which are now very mainstream and used commonly in children as well as adults. And sometimes, if they're really more severe, oral steroids or antibiotics. So when we're thinking of question number 3, front or PNS, postnasal space, or both. So in the front of the nose, the anatomical structures that can cause obstruction will be a septal deviation, turbinates, polyps, those foreign bodies, those sorts of issues, whereas postnasal space is going to be mainly adenoids, sometimes polyps, and rarely tumours. I know the others have gone through a little bit of examination, so I won't go through it too much, but I'll just say that the way that I tend to do it is outside in, so you look at the whole patient's face, then I'll look at the outside of the nose, the eyes, then I'll compare the sides of the nose, sometimes using my thumb to push up on the nose. No fancy instrument. And then to use an otoscope to have a look up the nose. Use a metal tongue depressor to look at airflow, listen to their voice, listen to their airflow, feel over their nose and sinuses, and then check other things such as their mouth and their ears and their neck, other areas associated with the nose. Of course, in ear, nose and throat practice, we tend to use nasendoscopes, which gives us a very panoramic look up the nose. So let's quickly go through some front of nose obstructions. This is looking up the nose now with the telescope. This is a septal deviation here. This is an enlarged turbinate, and this is a polyp. So it's important not to get the two confused. So polyps usually pale, glistening, almost like a grape inside the nose, whereas a turbinate is more pink and puffy and swollen and attached to the lateral nasal wall. In the back of the nose, we might have adenoids, we might have choanal which Justine mentioned, we might have nasal tumours. So usually to see these areas, you need either imaging or a telescope. I know that we went through some inferior turbinate reduction talk before, so it's quite a common procedure if you think that it's a structural problem with the turbinate to make more room inside the front of the nose. Adenoidectomy in children, so big adenoids here in the same, this is the x-ray here of this patient. So they will present with their nasal obstruction concerns or with infection concerns. So the indications to consider a patient for adenoidectomy would be obstructive issues such as snoring, feeding difficulties, blocked voice, drooling, facial dental growth anomalies, or recurrent infection, sinusitis in children, ear infections. They're the two indications why we might consider to do something about the adenoids. So just a quick summary of nasal obstruction, a practical approach. 1, think, do I need to worry? Secondly, is it a structural or a reactive swelling problem? And thirdly, is it a front of nose problem or back of nose problem? And that will really direct how quickly and in what direction you treat, investigate, or refer those patients. Let's have a look at this patient here. So just, if you can hear, that's great. I'll just skip through this video a little bit. He's a 2-year-old who's got increased work of breathing at night, often a dry mouth, had halitosis, bad breath, enuresis, which is bedwetting. They're tired and they're moody during the day. So I'm just going to bring it to here and watch this child breathing. Now, the thing that Virginia mentioned, which is really important, is often you don't hear big snoring in kids. So you can hear, if I stop talking, how tight that breathing is. But look at the chest, look at the tracheal tug, look at the mouth open, head back posture. So this is a child who will have really, really big tonsils and adenoids or really severe obstruction. And they're not snoring loudly, but they're really obstructive. So that's why a sleep study can be quite important. So let's talk about a practical clinical approach to sleep disordered breathing. So when it comes to it, again, let's talk about three key questions you should ask yourself as the clinician, as the doctor. So 1, what's the effect on the child's sleep quality? And Virginia mentioned quite a few different sleep issues that you can see. So it might be a head back, mouth open breathing posture, noisy breathing, work of breathing, sweaty, restless, or pauses in breathing. And then secondly, the effect on their daytime activity. So are they failing to thrive? Are they eating poorly and skinny, or the opposite way? Are they always tired? Are they obese? Do they have a dry mouth? Is there mood? Is learning going on? So the first thing is effect on sleep quality. Second thing is effect on daytime activities. And the third thing, which is really important as a clinician, is to think about the level of obstruction. And then and this is in children and adults, all of these go exactly the same for children and adults. And then you will work out whether you monitor, refer, sleep study, ENT surgeon, combination of both, where you go for these patients. So the consequences of sleep disorder breathing, children, Virginia went through this already, but there can be sleep issues, family issues, concentration issues, behavioural growth issues, as well as dental issues, and at the more severe, quite significant life-threatening concerns. So when I assess a child or adult, I take history and examination like you would with any patient. Sometimes you will use imaging, and in children, almost always a sleep study. In adults, depending on their clinical scenario, whether you would do something first or do a sleep study, depends on what you can see, as I will discuss later. So usually sleep disorder breathing or obstructive sleep apnea syndrome is a combination of structural concerns, tone concerns, or there might be other genetic factors such as a Down syndrome child might be more likely to have sleep disorder breathing issues. So assessment, again, use your thumb, use your otoscope, have a look and see. In our rooms, we tend to use telescopes. So let's talk about level of obstruction, because I think this is a really important way for people to think about sleep disordered breathing, whether it's an adult or a child. So if you have an adult or child, or your brother, sister, or parent who's snoring, and they ask you for advice, then this is what I would look at. So I always have, I see any of these patients, I think which level of the airway or which combination are involved. So I do about 5 levels of the airway with all of my patients. So one is the front part of the nose. Second level is the back part of the nose. Third is the oropharynx, which is the palate and tonsils. Fourth is the tongue base, which is really important in adults. And fifth is what I call further down south, which is the epiglottis, larynx, and that area. Because when someone has obstructive sleep apnea or snoring, it's going to be somewhere from the tip of their nose down to their larynx. That's where the obstruction is going to be for OSA. So they're the areas that I look at, the 5 different spots of the airway. So, let me just go back. So when you look at treatment, I look at those 5 areas and I direct my treatment to those areas. So it might be a front of nose obstruction with a big turbinate or septal deviation. So in adults, you might fix that first and then see how they improve and then go on and do sleep studies. In kids, this may be part of the treatment. Back of the nose, adenoids, polyps, tumours, so another important area to treat. The oropharynx, so here are really big tonsils now in the oropharynx. So in adults or kids, that's an important area. In adults, the tongue base is a really important area, and that's because adults tend to put on a fair bit of weight in their tongue bases. They get sort of 40 plus, so that's why snoring is so common in 40 plus adults. So in adults, tongue base is a really important area. In the old days, like 10 years ago, we used to laser a lot of palates in adults to try to help with their snoring, but we don't do that so often now because we know that it's usually not the palate, but actually the tongue base, which is where the problem is. So that needs treatment. And in some little kids and babies, it could be the epiglottis. This is the laryngomalacia. So floppy epiglottis, larynx is down here. So very narrow airway. So that's the 5th level. So that's the way that I tend to look at sleep disorder breathing, is looking at those 5 levels. And whether you're taking out tonsils or vaporizing adenoids, basically what you want to do is improve each of those 5 levels so that your child can breathe as well as they can. What's new in T's and A's? Well, we can pretty much do down to any age. So in tonsil adenoids, you can do down to 6-month-olds. Ideally, they'll be 10 kilos plus, but sometimes we have to do younger. With the more modern surgical techniques, there's less blood loss. It's more selective and less invasive. You can use shavers, coblators, lasers, and various things. And same with nasal procedures in kids. We can be more specific, less bleeding, and so a lot more sensitive. So they're all important factors. So let me just summarize in total. So from nasal obstruction point of view, 3 ways to look at it as a medical student when you become a doctor, sitting there at midnight in a peripheral emergency department. 1, should I worry? What are the red flags? 2, structure reactive. 3, front of nose, post-nasal space. And then how do I investigate, treat with what priority? Sleep disorder breathing in adults and kids. What's the effect on sleep quality? What's the effect on daytime activity? And then assess each of those levels of obstruction as best if you can with either examination or imaging to see which level you need to treat. And that is the end of my talk.
So thank you very much, Dr. Lowinger. I'm really happy that you were able to be here with us. We have one question.
Sure.
It's of Mariah. She said, how can allergies interfere in sleep?
Yeah, sure. So we spoke about 5 levels of the airway. So that's where the level number 1, which is the front of the nose. So the way that allergies affect sleep is by making the turbinate swollen. So by making turbinates swollen, it blocks the front of the nose, and that causes the concern. So that's the main area where allergies affect sleep. So often in kids, treatment of allergies is a really important part of their sleep management, as well as in adults.
Thank you. We don't have any other questions, but
Sure.
one more time, thank you for being here, for actually being present. It was really important for us.
No problem at all. If ever you come out to Australia to visit Virginia, you're always welcome to come to theatre and have a look and see what we do with patients as well. So always welcome. You should think of a elective term or something in Sydney. I'm sure you'd have a great time.
Thank you so much. It's definitely a possibility. So thank you. Oh, we have one more question, if you don't mind.
Yes, sure.
Can physical exercise help in the treatment?
I don't know where that picture's taken, but it looks fantastic. Sure, physical exercise is really important. In adults, it's very important because most adults, let's face it, snore because they're overweight. They don't have to be. And you do see some slim adults that snore as well. But especially in men, it's usually weight concern. So exercise is awesome for 2 reasons. 1, because you lose weight, and 2, because you makes you produce adrenaline. So that also helps constrict body tissue and helps with your sleep. So there are 2 reasons why exercise is really important. So if ever I have an adult who has sleep disorder breathing, I'll always talk about weight and exercise and diet, of course, as well.
Thank you. We have one more question.
Yeah, sure.
Okay.
How about surgery beyond 3 years old? In what way? What surgery, as in, do we do surgery beyond 3 years old, or which type of surgery? So with kids, as Virginia said, usually it's tonsils and adenoids or turbinates and allergy that's going to be the problem. So in 3 to 6 year olds, usually it's going to be tonsils and adenoids and no problem at all. But sometimes down to 5, 6 month olds even for that reason. If you have more than newborn up to 6 month old, that's probably more going to be something like a nasal structural problem or a laryngomalacia, or maybe a small jaw like in Pierre-Robin syndrome or something like that. So the younger cohort is going to be usually more something structural other than tonsils and adenoids, and then the 3s to 7s usually tonsils and adenoids, and then the older ones which can be septal deviations or tongue base or those sort of things. But there's no age limit to surgery. Today, the reason I couldn't pre-record was because I was actually on call at the moment. So I was in hospital today, and we had a little baby who's 3 weeks old who has obstruction and that we were operating on today. So there's no age limit. Oh, I think you're muted again, Julia. You're muted.
Thank you.
No problem.
I just wanted to thank you again one more time for being here and for all the explanations.
Okay.
It was a really amazing lecture.
Okay, great. And as I said, if any of your students want to reach out to students in Sydney, feel free, look up Josh, and I'm sure he'd be happy to put you in contact with other medical students here as well.
Okay, thank you very much. Have a nice day.
Bye.
Bye. So our next lecturer is Dr. Arthur Teng, who will be addressing sleep medicine in pediatrics patients. Dr. Teng is a senior staff specialist, pediatrician, and head of the Department of Sleep Medicine at the Sydney Children's Hospital in Randwick. Currently, he is a conjoint associate professor in pediatrics at the University of New South Wales. So sadly, he had an unforeseen event and he couldn't join us live today, but he was able to record his lecture and send it to us. So thank you, Dr. Teng.
Estou muito feliz e honrado da minha primeira palestra na América do Sul. Obrigado, Virginia. Pilosu convice. That is the end of the Portuguese part of my talk, I'm afraid. I'm very honored to be asked by one of my favorite ex-fellows, Dr. Virginia Oliveira, who was a fellow with me for 2 years. Thank you for the invitation, Virginia. I'm going to talk today about sleep disorders. And as an introduction, we'll talk about what is normal sleep in children. And then we go from infancy right up to teenage years with a special consideration of obstructive sleep apnea in the preschool age mainly. And we can talk about sleep disorders in teenagers, in adolescents. So thank you again for the opportunity. It is rare to learn about sleep in many medical schools, something that we have found in our own research from some years ago across various nations. 1 or 2 years, 1 or 2 hours in a medical course seems to be the average in most medical schools. So the number of hours of sleep does change with age. A newborn baby might sleep up to 18 hours or more a day, whereas the total sleep time decreases to old age, and most children will need around this amount of sleep. The type of sleep also changes with age, with REM sleep more common in younger children, and then less and less dreams as we get older. So in the first few months and couple of years, we have problems related to SIDS risk, which will be covered in more detail. My current Brazilian fellow, I think, is Dr. Marina Pimenta. But in the preschool age, snoring and sleep apnea becomes more common. And then towards the older school age, we have things like parasomnias, night terrors, etc. Movement disorders of sleep, such as periodic limb movement disorder. And then in late childhood, usually the emergence of excessive daytime sleepiness problems like narcolepsy. And then with adolescents, we have problems with sleep-wake phase delay or circadian rhythm problems. So the major advance in child health has occurred mainly due to research in New Zealand and Australia to avoid babies sleeping prone or on their tummies. So sleeping on the back is a very protective factor in decreasing SIDS rates. For example, these are figures from America, where the recommendation by the American Academy of Pediatrics in the early 1990s showed a decrease in the prone sleeping prevalence, which parallels the decrease in SIDS rates as well. When we move on to the graph again about the different sleep disorders, we can see that there are various challenges and indeed goals to be met as the child grows. The first few months of life, there is sleep consolidation, maturation of the neuronal system, and then in the preschool age, this coincides with rapid learning and motor and mental development. And that is when the tonsils and adenoids are the biggest. And therefore, snoring is a predominant problem in the preschool age. And then the hormones kick in adolescence. There are stress factors from the society. There are issues with substance abuse and indeed obesity, which can contribute further to different sleep disorders. Now I'm going to concentrate a little bit about obstructive sleep apnea. And this is not our usual patient, but this is Archie, who is one of the first patients that was started on CPAP. And he had very severe obstructive sleep apnea. And this is his oxygen saturation profile. You can see that the oxygen saturation drops down to very low levels through sleep. And this is the same patient on CPAP. Continuous positive airway pressure, you might know, is an invention of Professor Colin Sullivan in Sydney in 1981. And it is now the worldwide treatment of choice for adult sleep apnea. This is the post-mortem of someone with obstructive sleep apnea. You can see that there are blood blisters of petechiae on the pleural surface. So your intrathoracic organs have blood blisters. And this is the result of breathing efforts against a closed upper airway. And this is something that is found in about 80 to 85% of infants who die from SIDS. So the development of CPAP and the treatment of obstructive sleep apnea in adults gave rise in many ways to the development of pediatric sleep medicine. This is the adult picture of sleep apnea. They're usually men who are grumpy, overweight, and are sleepy during the day. In fact, as you might know, sleep disorders play a very important public health role in motor vehicle accidents and indeed industrial accidents as well. But this is the childhood picture of obstructive sleep apnea. They're usually skinny, not fat. They can have chest deformities. They are mouth breathers often by day as well as at night. They are not usually sleepy. They're usually hyperactive. They have behavioral issues. This is a video which I hope that you can hear. So this is the snoring, not as typical or loud as in some adults. And there are periods of silence which can be dangerous because this can represent pauses in the breathing. And then you can also see the increased breathing. That's why they're usually very skinny and they have chest deformities as well. Water breathing again, snorting. And if you listen to that, you might not feel that this is very loud snoring at all. So the definition of obstructive sleep apnea is a disorder that is characterized by prolonged or repetitive partial or complete upper airway obstruction that disrupts normal ventilation during sleep and disrupts normal sleep patterns. This is from Professor Sullivan's original paper published in Lancet. And you can see that in the normal upper airway, there is active dilatation of the upper airway muscles to keep the airways open. In obstructive sleep apnea, there is intermittent closure of the upper airways that results in blood gas abnormalities as well as disruption to normal sleep. How CPAP works is that there is a continuous blowing of air through the nose to splint the tongue forward and to keep the upper airways open. This is a picture of a 15-year-old boy, and this is 2 minutes per patient. You can see that there are repetitive obstructions. So in the sleep study, we measure EEG, eye movements, breathing parameters like diaphragm activity, chest and tummy movement, oxygen saturation, and you can see the nasal airflow going flat, not much compensation by mouth breathing, but increasing and lots of effort, usually resulting in an arousal. So this is the obstruction itself. This is the typical picture of childhood obstructive sleep apnea. It is usually large tonsils and large adenoids, which we cannot usually see because that's right at the back of the nasal passages and too superior in view to this throat. The take-home message, I guess, is the important symptoms of obstructive sleep apnea. This is from a study that was very well done in Montreal in Canada by Robert Briette, and he had 23 children with sleep studies, proven obstructive sleep apnea, and he compared the symptoms to 46 control children who did not have obstructive sleep apnea. And the three most important symptoms are, number one, snoring almost every night. That is in 96% of children, but only 9% of normal children. And then we have number two, the difficulty breathing in sleep. So they use their accessory muscles to breathe, and they usually hyperextend their neck. And the third one is the actual apneas, which is the stopping breathing in sleep. So these three things are the most important. The other things that are often very helpful are mouth breathing when awake and generally restless sleep, although this is specific. Something like 23 to 25% of parents will report that their children have a sleep problem or are restless in their sleep. 10% of children snore, but not all of them have obstructive sleep apnea. Another way of looking at it is that 90% of children do not normally snore. The ones who snore, there is a 1/3 chance that they might have obstructive sleep apnea. So the overall incidence of obstructive sleep apnea in the pediatric population is thought to be 3 to 5%. There are other less specific symptoms like sweatiness in sleep, recurrent ear infections. As you can see, excessive daytime sleepiness in only 1/3 of children with proven OSA, whereas this is present in up to 99% of adults with obstructive sleep apnea. Children with OSA also are very poor eaters. They often vomit, and they have sometimes difficulty swallowing. There are psychosocial problems as well associated with OSA. In infants, it can be even more non-specific. They can have non-specific respiratory distress, color change, feeding problems, chest deformity, metabolic alkalosis, failure to thrive, and even apparent life-threatening event. And we have put a lot of babies who have obstructive sleep apnea on CPAP as well. The risk factors, though, are important to know. Children with a very small mid-face, very large tongue or small mouth, and other syndromes. So these are cranial synostoses, which are the premature fusion of the skull bones. Down syndrome, we can talk about in more detail, but there's a very high incidence because of the very small mid-face, small mouth, and relatively large tongue, as well as hypotonia. The other risk factors are neurological problems like cerebral palsy, postoperative problems like post-cleft palate repair. There are miscellaneous disorders like obesity, Prader-Willi syndrome, abnormal metabolic problems, previous trauma to the upper airways. Now, a sleep study is a painless procedure in experienced hands. And this is what it might look like. Lots of stickers everywhere. The parent usually spends the night. And this is a very good paper by Virginia, who wrote this with me 5 years ago, looking at the usefulness of sleep studies, the different types of sleep studies that are done. But the fancy name for sleep study is polysomnograph. Polys meaning many in Greek, somnus, sleep, graphein, to write. And what is measured? Well, brain waves to stage sleep, or EEG, eye movements, or EOG, oculogram, electrooculogram. We measure muscle tone, we measure chest and tummy movement, we measure oxygen levels through the night, we measure airflow, not shown here, but that is often a thermistor on the lip to measure mouth breathing. The best way is the nasal prongs that measure pressure change in the nose, and then the ECG, cardiac rhythm, is monitored overnight. Transcutaneous CO2 is very helpful and used every night in our lab, as well as leg movements and audiovisual monitoring. This is a 2-minute page on the big boy, and this is slow wave sleep. On top, in a sleep study, you usually see what's called a hypnogram. A hypnogram is the distribution of sleep stages. Light sleep being green, deep sleep blue, red is REM sleep or dream sleep. And you can see graphically the EEG, the chin muscle tone, the chest and tummy movement, the airflow, the transcutaneous CO2, the oxygen saturation, and the leg movement. So this poor boy does have leg movement problems as well. These are called periodic limb movements, and the oxygen is quite low at baseline. So there is obstruction going on and obstructive hypoventilation. What is important to know is that unlike adults, more than one obstructive apnea per hour in children is regarded as abnormal, whereas in adults, this could be more than 5. Even in babies, it's been shown quite recently that they do not have also less than 1 per hour. And then the hypopneas are partial obstructive events. There should not be an increase of CO2 of more than 10 millimeters Hg now. And oxygen saturation should remain in the high 90s. But do we need to do sleep studies when the treatment is adenotonsillectomy? Well, we do sleep studies sometimes because the surgeon is uncertain whether they should do an operation or not. Because the last thing we want is unnecessary surgery. Adenotonsillectomy is often performed for recurrent tonsillitis, usually more than 5 in 1 year. But it is also performed for obstructive sleep apnea, which is the main reason now in major hospitals around the world. And so the sleep study serves to clinch the diagnosis. But is tonsillectomy very curative? People used to think that it's the 100% cure, but there's very few 100% cures in medicine, as you know. And overall, the only thing you need to know is that the cure rate for adenotonsillectomy on an average child really is only about 83%, which means that 17% of otherwise normal children might still have obstructive sleep apnea after adenotonsillectomy. If you count the children with those risk factors, the failure rate can be even as high of more than 50%. One of the most important studies came out now 8 years ago from America, and this is the CHAT study, which many of you might have heard of. The age range, it's very important to know, was 5 to 10 years. A lot of criticism was leveled against the study because they said that they missed the peak incidence, which is 2 to 4. Anyway, this was an important study of a large study, relatively large study, where they were randomized to adenotonsillectomy or watchful waiting and normal care. The cure rate was 80% overall, but if you waited 7 months, almost 50% got better in terms of a sleep study. If you were African Americans, the cure rate was less, and the resolution rate was also less. If you're obese, the cure rate was even less, and the less resolution as well. But if you took out obesity, the 85% cure rate was achieved and about 54% resolve. So the children that were included were not the most severe. So if you were stopping breathing more than 30 times per hour or 20 times per hour complete obstructions, or saturation of less than 90% for 2% or more of the total sleep time, you were excluded from the study. So they didn't want to look at the most severe. The interesting thing was that it did not change the executive function as measured by neuropsychological testing. Other studies have shown no change in IQ, but the parents reported much better behavior, and they were also better in terms of the quality of life, and the sleep study, of course, improved as well. So there is a benefit, of course, from adenotonsillectomy. But the problem with adenotonsillectomy is that there could be complications, and that is the risk. And the worse your sleep study, the worse your complication rate. So children do die postoperatively. They seldom die from obstructive sleep apnea itself, at least not in the school or preschool age. But if you had these risk factors, you have to be watched very carefully. And they probably should be done in a major children's hospital. So alternatives include questionnaires, NAP studies, audio taping, videotaping. Oximetry seems to be the best, but oximetry alone is not the best solution because you can have very severe obstructive sleep apnea and still not drop your oxygen, but have very bad sleep. So the best way about thinking about sleep disordered breathing is the spectrum. Normal and no snoring, severe and complete obstruction. Primary snoring is noise, no change in blood gas or sleep structure. UARS is where there is degraded sleep quality, but still normal oxygen and CO2. But then when you have partial obstructive apnea, you move towards the more severe. Going on to the older children now, we have things like periodic limb movement disorder, where the leg movements occur. And you can see this in the video if you look very, very carefully right at the legs. And this is not the sudden jerky movements that we often see when we first go to sleep, but it's a slow writhing movement. It's like a positive Babinski reflex. So it's the upgoing toes. There are various criteria. You have to have 4 in a row, can't be separated by more than 30 seconds, and a certain size, and more than 5 per hour is considered abnormal in children. In adults, more than 10 periodic limb movements might be considered abnormal. So we do measure this usually above 12 months of age, and they can be quite symptomatic. And some of them have very restless sleep, they have growing pains, etc. So here's another one. That's a beautiful signal. So this is the periodic limb movements again, and you can see that it is sometimes very fragmenting to the person's sleep. And the pains are sometimes very hard to talk about for the child, and they can draw it, like a burning or tight feeling, electrical vibration, pins and needles, a tapping feeling. These are my own patients. And the restless leg syndrome is related to periodic limb movements. This is usually diagnosed only on history. There's an overlap. A lot of people with periodic limb movements have restless legs. Not everyone with restless legs have periodic limb movements. And then if you don't sit still and you have fragmented sleep, you can't concentrate during the day. So they often during the day have ADD. And if you snore and have sleep apnea, there's further fragmentation of sleep as well. So they can be overlapping problems. And the problem seems to be centered on the underactivity of dopamine as the neurotransmitter. We don't have time to go that in more detail. The last thing I want to cover is the excessive daytime sleepiness. So in children with narcolepsy, which is really a debilitating and lifelong neurological condition, they are often misdiagnosed. The diagnosis is often delayed, and they are very sleepy. They can't stay awake. They have episodes of sleep attacks. They have sudden loss of muscle tone called cataplexy, usually in response to high emotion like laughter, and they have hypnagogic hallucinations, which is the hallucinations awake of seeing their own dreams when they're awake. So it can be very scary. And sleep paralysis, where they can't move their legs or feet when waking up or falling asleep, which can happen in normal people who are usually sleep deprived. Automatic behavior is when they do something and they forgot, like they open the fridge to get a drink, and then the next moment they can't remember why they opened the drink, the fridge. Delayed sleep phase syndrome is common in adolescents. These are children who cannot sleep early enough to wake up refreshed the next day. And as you go into teenage years, it becomes more and more common. It's got to do with melatonin secretion, usually delayed and reduced in puberty. Plus, teenagers need a lot of light. They need a lot of devices. They often use it inappropriately when we're meant to be in a dark environment. And they're at risk because there is a circadian rhythm delay, which is a biological thing. And there's also a decreased rise. They tend to feel less sleepy as they get into teenage years. And then they have a lot of psychosocial pressure. There's pressure for screen time, social pressure, academic pressure. They are trying to be autonomous of their parents and be independent. And then they have school start times that's often too early in high school. And all this is what has been called by Mary Cascadon, one of the modern pioneers of sleep medicine, to be the perfect storm. So that is the summary of different sleep disorders with different ages. So once again, obrigado, Virginia, for this invitation, and I hope you've enjoyed it.
So thank you one more time, Dr. Tang, for sending us his presentation. And now our next lecturer is going to be Marina Pimenta, and she'll be addressing the sudden infant death syndrome. Dr. Pimenta has specialization in pediatrics, subspecialization in neonatology, and she has also a doctorate in medical science and an improvement in emergency pediatrics at the Children's Hospital at Westmead in Sydney, Australia, and in neonatal ICU at the Centro Hospitalar São Francisco Xavier in Portugal. Currently, she's doing a fellowship in sleep and obstructive sleep apnea. So, thank you, Marina.
Oi, gente, tudo bem? Meu nome é Marina. E tá dando eco? Tá tudo bem? Tá me ouvindo?
Sim, aqui tá ótimo. Pode continuar.
Tá. Eu sou pediatra pneumologista, formada em BH pela FEMIG, e eu vim, graças a Virgínia também, para fazer um fellowship em sleep aqui. E o meu chefe é o Dr. Tang também. E eu vou falar um pouco, vou fugir um pouco do assunto de todo mundo. É uma coisa que é muito ligada a sleep, mas eu vou falar de SIDS. Então, SIDS, que em português é a morte súbita do como é que fala infant mesmo? Do recém-nascido. Em português, tá? Eu vou fazer minha palestra toda em inglês. O meu inglês não é tão bom quanto o da Virgínia, mas acho que vai dar para todo mundo entender, tá bem? Eu vou fazer o share screen aqui agora. Onde que eu vou? Deixa aqui. Just give me a minute. Share screen. Share screen. Oh, keyboard. Só um minutinho que eu tô chegando lá.
Sure.
Aqui, ó. Chegando bem. Okay. Slides.
Aí não, peraí. Meu computer.
Você precisa de alguma ajuda ou tá?
Não, acho que tá tudo bem. Só tô achando aqui que eu tô no computador da Virgínia também.
Sem problemas.
Só um minutinho. Ok. Só fazendo o upload. Eu vou deixar o meu e-mail aí no final, para quem tiver qualquer questão, qualquer pergunta sobre o assunto ou sobre a Austrália em geral. Vocês podem me mandar à vontade. Estamos quase lá.
Sem problemas. Você tá gostando daí ou tá com saudade do Brasil?
Tô com saudade do Brasil, mas eu acho que eu gosto mais daqui do que a saudade do Brasil aperta. Tô achando bem bom. Já tô fazendo quase 2 anos aqui, né? Eu fiquei 1 ano full time lá no hospital e agora eu tô part time no hospital, mas aí vou fazer mais, né? Tô acabando meu 2º ano.
Então,
Tá dando para ver aí? Tá tudo certo?
Tá certinho, pode começar.
So, I'm going to speak about SIDS, and SIDS stand for Sudden Infant Death Syndrome, and it was previously called crib or cot death. I imagine that's not a big thing in university. I've studied it very, very briefly when I was in med school, so that's why I thought it would be interesting for everyone to know a little bit about it. So sudden death on an infant, when we say infant here is younger than 1 year of age, it has to be a death which remains unexplained after thorough case investigation, including performance of a complete autopsy, examination of death scene, and review of clinical history. So after you exclude every explanation for the sudden death, that's when you can call it SIDS. So if you get sudden unexpected infant death, that's a broader term. You divide it in explained ones. That would be suffocation, asphyxia, entrapment, infection, ingestions, metabolic disease, arrhythmias, and the unexplained one that we would call it SIDS. A lot of disorders can mimic infant death syndrome, and I put down a few of them. And one of the most common one would be sepsis. So the leading cause of infant mortality in infants younger than 1 year in the US is SIDS, and the risk is below 1 per 1,000 live births, in which 15 to 20% of the cases occur in childcare settings. It is slightly increased in boys, and even if it's high, it's still, even if it's low, it's still 20-fold higher than the risk of death during any of the subsequent 17 years of life due to any other cause, and being traffic accidents, firearms, drugs, overdose, and suicide. Incidence of SIDS has declined dramatically over the last 10, 20 years, and it is due to the campaign Back to Sleep. So it has decreased to half. Nowadays, proportion of infants sleeping in the supine position increased from 13 to 72%. This is a landmark study. It was done in 1988. It was a population-based, case-controlled, that include 10% of all the live births in the US, and it was published in 1988, as I told you. And after that study, that's when they realized that we needed to focus on SIDS. Most of the risk factors are similar to other sleep-related infant deaths, such as suffocation, asphyxia, and entrapment. And you can see that we have a lot of risk factors. I'm going to go through each one of them slowly to show you what we can do to prevent that. So one of the biggest risk factors is maternal. So the two major maternal risks would be maternal smoking and mother's age below 20 years of age. So young mothers, children of young mothers, they are in greater risk of SIDS. Maternal smoking is an important modifiable risk factor, and the rates increase with the amount smoked and decrease if mother quits smoking during pregnancy or even afterwards. The strongest effect is during pregnancy, but exposures to secondhand smoke after birth, it's also an independent risk factor. Studies have shown abnormal cardiovascular response and impaired arousal to stimuli in infants born to mothers who smoked during pregnancy, and that's the biggest mechanism on why they think SIDS occur. We also have a 5-fold increased risk in infants of substance abusing mothers. So it's not just tobacco, also drugs and alcohol abuse. And it's not known if this association is related primarily to the biologic effect drugs in uterus. It could be also because it increases risk of prematurity and low birth weight. And we have other postnatal conditions, such as child maltreatment. So we never know if the mother is neglecting intentionally or non-intentionally the child. We also have placenta previa, placental abruption, premature rupture of membranes, and elevated maternal alpha fetal protein as risk factors for SIDS. As for the infant risks, we have prematurity and low and very low birth weight as the main risks. It increases 3 to 4 fold, and the peak of vulnerability is 4 to 6 weeks earlier among preterm infants. Nowadays, populations of low birth weight infants seems to be experiencing a decline, and now it is similar to the general population. If you have a child that died of SIDS and you have another child, so this sibling of SIDS victim has 5 to 6 times increased risk of SIDS. It could be either from biological, epidemiologic, or environmental factors, such as inborn errors of metabolism, child abuse, and severe deprivation and poverty. You would think that in the same family you would have a few similar risk factors between siblings. The crude risk of SIDS between twins, it is twice if you compare it to the singletons. They think it's because most of them, they are preterm or they are born with low birth weight. But studies have shown that even amongst twins born over 37 weeks or with the weight above 3 kilos, the risk is still increased if you compare it to single children. History of apnea, ALTI, and Bruy. I don't know if you know ALTI and Bruy. So ALTI would be a parent life-threatening event, and nowadays it's called Bruy. It's brief, resolved, unexplained event. So history of apnea or either one of these or other abnormalities in breathing, they're not clinically useful predictors of SIDS. And history of cyanosis also does not increase the risk of SIDS victims. This is a study done in the early 90s, and it showed that approximately 5% of parents of SIDS victims recalled cyanotic episodes, but also parents with control infants, they did recalled cyanotic episodes or any of that ALTI episodes. So it doesn't really it doesn't add anything to us. Monitoring for apnea using those monitors that we have at home does not reduce SIDS risk. I put here a few studies, a study published from American Academy of Pediatrics. And here you can see that they do not recommend the use of monitors, home monitors for SIDS. One of the most important modifiable risk factors is sleep position. So it was the rate of SIDS was significantly decreased in a lot of countries after the campaign that I told you, because now infants, they are placed to sleep supine instead of prone. And as we've seen increased infants not sleeping in prone, parents are usually putting them sides, and now we have increased SIDS risk in side sleeping as well. So we should avoid prone and side positioning when putting an infant to sleep. The use of sleep positioners, I don't recall how to call them in Portuguese, but it's something that you put around the baby so it won't change positions. It has also been associated with several cases of infant deaths, and the US Food and Drug Administration do not recommend it. We should not place the infant to sleep in a soft sleeping surface, so we should always use crib or cot that is designed for that specific age. And sleeping on a soft sleeping surface could increase SIDS risk in 5-fold. The combination of prone positioning and soft bedding would increase it in 21 times SIDS factor, SIDS risk. Loose bedding accessories should not be used as well, as the risk is increased 5 times. So blankets, quilts, pillows, stuffed toys, sheepskins. So everything that you can see on the pictures here, we should not use it. So a baby up until at least 1 year of age, they shouldn't have anything in the cot. When they start moving and they can get away from everything that's obstructing airway, then we can think about having, for example, an aninha or something that comforts them. Crib bumper pads also, sorry, I don't know the name in Portuguese, but it has been associated to suffocation, and the rate appears to be increasing despite recommendations against the use of the bumper pads. So everything that we put in the crib or cot or bassinet is a risk for the child. We should not recommend parents to share their beds. Some authors showed that it could be controversial because it is easier for parents to have the child close to them for breastfeeding, for example, increasing parents' sleep. And in a lot of places, we know that's cultural. But breastfeeding parental sleep, for example, it could be supported by room sharing and not bed sharing. So do not place an infant in your bed. It's also not recommended to put twins or any children, any number of children together in the same crib or bed. Car safety seats are for car travel only. Sitting position may reduce oxygenation in young infants, and there's been cases of suffocation after a car seat accidentally turned when placed on a sofa bed or a couch or something like that. Of course, car seats have the safety benefits and it outweigh the small risk of SIDS, but it's recommended by Australian Association and American Association to use it only for travel. Overheating should not be used. So there's been a few studies, they're not very big studies, but they found a relation between patients with, for example, this one that I'm showing you, between an infant with 2 or more layers of clothing with SIDS. So no, don't overheat, don't put a lot of clothes, don't cover the infant, the child in blankets. Do not put a heating or anything that would increase room temperature. The mechanism is not very well known. They think it could have something to do with head covering and rebreathing or just getting the body temperature higher. Swaddling, it's a big factor, but for older infants. So if the older infant attempts to turn and the baby is all swaddled, so it doesn't have hands and he can't move, it could take him, it could suffocate, the baby could suffocate or just, for example, if you have a pillow or a naninha or a blanket, it could come to their faces and they cannot turn. They also less likely to be aroused by external stimuli. And this all counts for infants that are not used to being routinely swaddled. If the patient is supine, they don't see a lot of relation between SIDS and swaddling. So room sharing is a protective factor. As I told you, no bed sharing, but putting the baby, as you can see in the picture, close to mom. In Brazil, I don't remember if we had an age that would be safe to put the baby in its own room. But here we always talk about 4 to 6 months, but it's not established. But for the first few months of life, the infant should be placed in parents' room, not with another child. So a brother or sister, it doesn't count. It has to be in an adult room. Breastfeeding is also protective, and it's an independent effect against SIDS. Any breastfeeding, at least for 2 months, will reduce SIDS in half, the risk of SIDS in half. And if you keep breastfeeding, you have more protection against SIDS. Exclusive breastfeeding do not confer additional benefits over partial. So if you are breastfeeding, the child is protected against SIDS. The pacifier user, here we call it dummy. So it is a protective factor. It is recommended whenever you have breastfeeding already in a good position, a good way, you can start using pacifiers. The mechanism of association is unclear, and AAP suggests using it, but you start the sleep with it, don't try to put it back in the middle of the night. So just start sleep. It's just to calm them down and give them some comfort. It is important for me to say that SIDS is not associated with any vaccine, including the DTP. So a lot of people...
Oi, gente, tudo bem? Aparece da... Só um instante. Hi.
Hi.
Your internet just like stopped working.
Okay. All right.
Can you restart?
Where did I stop? Here?
Yeah.
Okay. All right.
Thank you.
That's okay. So immunization, it's important for me to say that it's not associated with any vaccines, mainly DTP. We always think that pertussis would, it might increase SIDS, but it doesn't. So immunization may lower the risk of SIDS. So just give all the vaccines that you can to your children. Pathogenesis of SIDS is little known, and the mechanism of death, it's a bit unclear. We have a triple risk model, as you can see in the picture there, that has been proposed, and they suggest that the infant that die of SIDS, it might have an underlying vulnerability, so underlying disease. It might experience a trigger event, and it could be in a vulnerable developmental stage of central nervous or immune system. Again, there is no benefit from home monitors. That's very important. Here we see all the time patients wanting monitoring. I don't know if you have that in Brazil, but here we have like a little sock that you can put on the baby's foot. And we do not recommend that for SIDS. So there's no evidence whatsoever to support the role of home monitors for prevention. And the AAP, the American Association of Pediatrics, recommends against it. We also know that the negative side of home monitoring would be anxious parents, because with the false alarm, they would go out of their minds, as I don't know if everyone know, anxious, very anxious. Parents might feel falsely reassured using that and might not do all the rest that we talked about. And with the marketing strategies, it could make parents a bit more fearful of SIDS than they should be. So all parents should be advised about how to minimize risk of SIDS, especially regarding safe sleeping position and environment, most of all. And I want you to really know and to take home and never forget that the vast majority of SIDS victims do not experience acute events or apneas or cyanosis or any other breathing event prior to death. And clinicians should be aware of what a safe sleep is, what are the recommendations for infants, and reinforce the importance during infancy as part of a routine, a guidance to families. And a reminder, very big reminder, Aute or Brui is not related to SIDS. So that's a very important message here. And I think that's it. I tried not to be too long. I hope you enjoy that. And I'm happy I put my email there. So if anyone wants to email me, just feel free to do it. And if you have any questions, I'm here.
So hi, thank you for your lecture. Your internet stopped again, just like by the very end, so it's okay. I'm just saying like you're finished, so there's no problems. Well, we have a question. So does bed sharing have an influence in SIDS?
Yes. Vou responder em português, né? Júlia deve ser brasileira, Júlia Nunes. Sim, então você dividir a cama com um infant, né, com um bebezinho, principalmente o recém-nascido, principalmente aquele bebê que ainda não rola, que ainda não mexe. Tá dando para ouvir? Tá tudo certinho? Acho que caiu de novo. Tá tudo certinho?
Voltou. Pode responder.
Então, você dividir a cama, um adulto dividir a cama com uma criança, com um bebezinho, né? Que principalmente aqueles que não se mexem muito, que não conseguem virar, que não conseguem se mexer e não conseguem sair daquela posição que seja perigosa para ele. Sim, aumenta, se eu não me engano, aqui 5 vezes o risco de SIDS. E se for conjunto com prone position, né? Se ele estiver de bruço, aumenta 21 vezes o risco de SIDS, sim. Então, o bed sharing é realmente proibido.
Isso é uma coisa que eu já ouvi falar muito mesmo.
Sim. E os brasileiros continuam colocando os bebês para dormir com eles. Aqui também. Não é só brasileiro, não, viu, gente? Muita gente faz isso.
Eu não sabia, né, que é uma coisa que a gente pode instruir até mesmo no postinho e tudo mais, né?
Sim, de pré-natal, até consulta de pré-natal, sabe? Eu acho que já para... Porque... Eu não sei vocês, mas eu fui aprender sobre SIDS na residência de pediatria e mesmo assim não é muito falado. Aqui a gente fala muito mais disso, por isso que eu quis trazer isso para vocês, que eu acho que são poucas coisas que você pode oferecer para os pais, são poucas sugestões que podem fazer a diferença, sabe? Então acho que é muito importante a gente ter isso na cabeça.
Com certeza. Muito obrigada, viu, Marina?
Obrigada pelo convite, viu, gente?
A gente ficou muito feliz de ter você aqui.
Obrigada, bom dia para vocês.
Para você também. Boa noite.
Boa noite, tchau.
Tchau. Bom, agora nós vamos iniciar o próximo bloco do nosso evento. E a nossa moderadora será a Júlia, que já está aqui com a gente. Ela vai ser a moderadora do nosso evento em português. Caso você queira, né, ver o evento em inglês, você pode sempre ir para o outro link do YouTube, onde a gente está tendo um tradutor que está traduzindo todo o evento. So in case you want to listen to the event in English, you can actually go to our YouTube and change the link. We have one link there where you're going to be someone translating the whole event. So, Júlia, muito obrigada por estar aqui com a gente e por estar moderando essa parte do evento.
Bom dia, pessoal. Vamos dando um seguimento aqui, então, continuando com o nosso evento, porque estamos com o horário um pouquinho corrido. Então, eu já vou iniciar apresentando. A gente vai dar início agora ao nosso segundo bloco, ao bloco de asma. E quem vai falar primeiro é a doutora Mariana Vieira, que vai abordar o tabagismo e sua associação com a gravidade da asma na criança. Ela é pneumologista pediátrica pelo Hospital das Clínicas, mestranda em asma grave pela UFMG, preceptora do Serviço de Pediatria da Santa Casa de Belo Horizonte e plantonista do setor de urgência pediátrica no Hospital Ipsente. Ei, doutora Mariana, bom dia.
Bom dia, gente, tudo bem?
Tudo. Muito obrigada por estar aqui hoje e contribuir com o nosso evento. É uma honra para a gente ter aqui. E, por favor, fique à vontade para iniciar a sua palestra quando você quiser.
Ótimo. Primeiro, eu queria agradecer o convite de vocês. É sempre bom poder contribuir um pouquinho, ainda mais falar sobre um tema que é tão relevante, né, com relação ao controle da asma e o tabagismo, tá? Então, eu vou fazer a minha palestra. Eu deixei meu e-mail, caso vocês queiram tirar qualquer dúvida ou que eu envie qualquer material para leitura, tá? Então, estou sempre à disposição de vocês, tá? Vou compartilhar minha tela, então.
Beleza.
Vocês estão vendo minha apresentação?
Sim, estamos sim.
Então tá, vamos lá então. Então, eu tive a missão hoje de falar um pouquinho sobre o tabagismo e a associação com a gravidade da asma por toda a infância. Começando aí, nós vamos fazer uma reflexão desde o período gestacional e o contato da mãe com o cigarro até o período da adolescência. Bom, o roteiro da nossa aula, primeiro a gente vai fazer uma introdução, entendendo um pouquinho o contexto do tabagismo, sobretudo aqui no Brasil, que eu acho que é um problema importante de saúde pública. O segundo ponto que nós vamos falar é um pouquinho do tabagismo passivo, tanto na gestação quanto na infância. Por fim, vamos falar sobre o tabagismo ativo na adolescência e o que podemos fazer, né? Qual a abordagem que podemos fazer em relação a essa associação de tabagismo, então, no contexto de asma. Bom, então, introduzindo um pouquinho, a gente sabe que acho que no mundo inteiro, né? Não tem como a gente particularizar só no Brasil, o tabagismo é ainda um grave problema de saúde pública, né? A gente tem visto que a questão do tabagismo tem índices menores nos últimos anos, mas mesmo assim ele tem gerado um impacto econômico importante, social e ambiental em todo o mundo. Isso porque, além de causar poluição, desmatamento, né, dependência, ele pode ser fator de risco para várias doenças, não só respiratórias, né, como tuberculose, infertilidade, osteoporose. Ele é responsável por 1 em cada 10 mortes, sendo que é 1 em cada 4 homens e 1 em cada 20 mulheres, lógico, relacionado a todas essas doenças. E a última informação que eu quero trazer é que ele é responsável por 63% de óbitos de doenças crônicas. E aí, então, entra, né, dentre as doenças crônicas, a asma, que é uma doença importante aí por toda a faixa etária, não só pediátrica, mas também quanto ao adulto, uma asma não controlada. Bom, segundo dados da Organização Mundial de Saúde, o tabagismo, né, entra, seja ele ativo como ele passivo, ele entra como as principais causas evitáveis de morte no mundo. Então, a gente tem o tabagismo ativo como primeira causa e o tabagismo passivo como a terceira causa.
Bom, e por que então a gente fala tanto que o tabagismo vai ser prejudicial com relação ao trato respiratório, já que esse é o nosso foco hoje? Pela ampla gama de substâncias que ele contém, né, na sua composição. Então, se a gente for fazer uma retrospectiva, o cigarro, ele tem acetona, que é aquela acetona que a gente remove o esmalte. Ele tem a terebentina, que dilui tinta a óleo. Então, assim, são componentes muito tóxicos. Contém o formol, que a gente usa para conservar cadáver, né? Contém o fósforo P4P6, que é utilizado inclusive para veneno de ratos. Ele tem componente de naftalina, que mata insetos como baratas. E tem amônia, que é um potente desinfetante, né? Para azulejos, pisos. Então, imagina juntando todos esses componentes, a toxicidade que isso vai gerar para as nossas vias aéreas, né? E aí, por isso, então, a gente sabe que dentre essas substâncias, principalmente quando esse cigarro ele é queimado, a gente vai ter, né, a produção da nicotina, que vai ser capaz de gerar vários efeitos colaterais, principalmente respiratórios, cardiovasculares, câncer. O monóxido de carbono vai ser responsável pelas doenças cardiovasculares e respiratórias. Eu tenho uma produção de mais de 70 substâncias carcinogênicas. E as substâncias irritantes de todas essas que eu falei para vocês, quando elas se queimam, vão ser responsáveis pelas doenças respiratórias. E o nosso foco hoje é falar, então, um pouquinho do impacto disso em relação à asma. Bom, a gente sabe que a asma é uma doença inflamatória heterogênea, uma doença inflamatória crônica, né? Das vias aéreas, que vai ser caracterizada tanto por uma hiperresponsividade, ou seja, qualquer substância ali que gere, né, um padrão inflamatório, aquela criança ou aquele adulto, adolescente, vai se responder com uma hiperresponsividade, né? E vai ter relacionado a isso a uma limitação ao fluxo aéreo pela broncoconstrição, pelo edema gerado, pela congestão vascular que aquele processo inflamatório gera e pela presença de muco. Então, todos esses fatores vão gerar essa inflamação crônica das vias aéreas. E aí o tabagismo ele entra como um fator primordial, né? Já que ele funciona como um principal agente irritante. Então, a exposição ao tabagismo ela vai permear aí o controle ambiental e isso vai ocasionar a dificuldade do controle dos sintomas. E eu acho que é isso, então, que é o foco da nossa aula, a gente entender como que esse tabagismo vai estar relacionado à dificuldade do controle dos sintomas. Então, para a gente fazer essa associação entre tabagismo e asma, a gente tem que entender o contexto do tabagismo passivo desde a gestação e o período da infância, e entender também o tabagismo ativo na adolescência, né? Porque a gente tem os nossos adolescentes agora fazendo cada vez mais uso de cigarro por um comportamento mesmo do momento da fase que eles estão vivendo. Bom, então falando um pouquinho de tabagismo passivo, eu gosto muito desse memezinho, né? O que os olhos não veem, o pulmão sente. E é exatamente isso que o tabagismo passivo quer passar, né? Às vezes, o que a gente não está tendo tanta noção ali, né? Eu não estou fazendo uma coisa ativa, eu não estou tendo... a criança não está fumando, o feto durante o período gestacional não está realmente tendo ali o contato efetivo com o cigarro, mas o pulmão dessas crianças vai sentir de algum momento em razão dessa exposição. Bom, a gente sabe que o tabagismo passivo é a terceira causa evitável de morte no mundo, né? Dados recentes aí da OMS mostram que a prevalência é de 2 bilhões, né? Então, eu tenho dois tabagistas passivos, né, para cada fumante, então é muito, né? No Brasil, isso é responsável por mais de 6% da exposição ao fumo no domicílio, e isso é responsável por mais de 1,2 milhões de mortes prematuras, gente. Então, a gente está falando de muitos bebês, né, que estão relacionados mesmo ao tabagismo passivo. E um dado que chama muita atenção é que mais de 60 mil crianças morrem ao ano por doenças atribuíveis ao fumo passivo, e claro que isso inclui a asma, né? Bom, mas como que então? O que acontece, então, né, nesses períodos da infância?
A gente sabe que no Brasil, 1 em cada 4 gestantes é fumante, e em cerca de 50% delas, a gente não consegue abandonar, elas não conseguem abandonar o hábito, mesmo depois de, nas consultas de pré-natal, ter sido esclarecido sobre os riscos. Os fatores de risco para as mamães, né, as gestantes tabagistas, são a idade, que é menores de 20 anos, o ensino médio incompleto, mães solteiras e sem cuidados pré-natais iniciados no primeiro trimestre, quando as gestantes ainda estão fumando uma quantidade importante aí. Bom, e aí eu trago um trabalho para vocês. Esse trabalho é um trabalho antigo, de 2005, mas é um trabalho muito importante na pneumologia pediátrica, desse autor, que é um autor chileno, que é o Dr. Castro Rodrigues, e é que ele tenta trazer a relação de sibilância e asma na infância, tentando mostrar alguns fatores de risco. E uma coisa que chama muita atenção é que quando ele começa a ver, né, nessa primeira curva aqui, igual eu mostro na setinha para vocês, aquelas crianças que têm uma sibilância, né, que é transitória, mas elas começam a ter uma sibilância ali desde os primeiros meses de vida, tem um pico ali em torno de um ano e meio, e depois isso começa a cair em torno dos 3 anos. E aí uma coisa que chama a atenção desses pacientes que têm essa sibilância transitória é que eles têm uma história familiar, né, uma história materna de tabagismo durante o pré-natal. E isso é uma história muito forte, tá? Então, acaba que chama atenção um pouquinho mesmo com relação a essa sibilância que tem um início precoce na infância, tá? Voltando um pouquinho aqui nesse gráfico, a gente vê que a segunda curva, né, que na verdade essa curva cheia aqui, que são os asmáticos mesmo, aquelas crianças que começam a sibilar, né, um pouco mais precocemente, não tanto quanto sibilantes transitórias, mas que perduram essa sibilância, e aí sim tem uma doença associada eosinofílica, né, uma asma eosinofílica associada a IgE. Essas crianças também pode ser que tenham uma história familiar, não tão importante quanto essas crianças que chiam aí, que sibilam até os primeiros 3 anos, mas sim tem um componente importante também com relação à história materna de tabagismo, certo? Bom, e aí eu trago para vocês esse outro trabalho que foi publicado recentemente. É um trabalho que tentou avaliar, né, a ocorrência de sibilância transitória, asma persistente e rinocinusite. E foi um trabalho muito legal, de autores basicamente alemãos, desculpa, que envolveu mais de 10 mil pacientes, envolvendo 5 coortes com pais tabagistas, ou seja, mães tabagistas, né? E foi acompanhando essas crianças até mais ou menos 14, 16 anos, para tentar ver exatamente o quanto que aquela mãe que fumou durante a gestação impactou na ocorrência de asma, né? Aí durante ao longo da vida dessas crianças. E o que a gente vê basicamente nesse trabalho é que, aqui nesse gráfico, mostrando uma odds ratio, né? Mostrando que tanto a asma em pretinho, em que a gente viu que tanto a sibilância transitória quanto a sibilância persistente, então eu estou falando de asma, a gente teve realmente um aumento de risco com relação àqueles pacientes mesmo, né? Que tiveram a mãe aí fazendo uso do tabagismo na infância, certo? E o que acontece, né? Se a gente for pensar na fisiopatologia, por que essa mãe fumante durante o período gestacional vai favorecer a ocorrência de sibilância transitória e de asma? Primeiro, porque o cigarro, né? O cigarro, com todas essas substâncias tóxicas, ele vai promover modificações epigenéticas. Então, eu tenho mutações nos genes que vão regular a formação de proteínas inflamatórias nas vias aéreas, favorecendo, então, essa inflamação crônica de todo esse trato respiratório. Além disso, eu vou ter uma alteração na imunidade inata e modificação na liberação de linfócitos nas vias aéreas, o que vai favorecer também a ocorrência de infecções de sibilância induzida por vírus, e aí eu vou favorecer nessa inflamação do ponto de vista crônico das vias aéreas, certo? Bom, Na infância, isso acaba ocorrendo de uma forma mais importante, porque as crianças, talvez elas sejam as mais afetadas dentre os fumantes passivos, por passarem mais tempo expostas à fumaça, principalmente quando o fumante é a mãe, ou é a cuidadora ou cuidador, né? E pelo fato primordial de serem impotentes na mudança dessa situação. Não tem como elas saírem ali de casa daquele contato, né? Então, elas vão estar muito mais expostas ao tabagismo, certo? Bom, e já tem vários trabalhos mostrando que a faixa etária mais atingida, então, são os menores de 5 anos de idade. E por que isso? Porque nós sabemos que nessa faixa etária a gente ainda tem um desenvolvimento incompleto do sistema respiratório, sobretudo no que tange ao ganho de função pulmonar. A função pulmonar, nós sabemos, né, de trabalhos, já vários trabalhos importantes aí, que ela é bem estabelecida até os 8 anos de idade. Então, a criança está ganhando função pulmonar até essa idade. Depois de 8 anos, de 8 até 20 anos, a gente ganha ainda, mas é muito menos, né? E depois dessa faixa etária, a gente tem uma estabilização para a partir dos 30 anos a gente ter realmente uma queda dessa função pulmonar, né? Então, se eu tenho um ganho de função pulmonar e, ao mesmo tempo, eu estou exposta a essa substância tóxica irritativa, né? Isso vai ter uma consequência, então, nesse desenvolvimento do sistema respiratório. Além disso, se a gente for fazer, né, uma comparação do volume de substâncias inalatórias por quilo, né, pelo quilo da criança, proporcionalmente é muito maior do que no adulto. Então, isso vai ser capaz, né, de gerar edema de mucosa respiratória. Eu posso ter hipertrofia e hiperplasia celulares de todo o trato respiratório, o que vai ocasionar a redução do clírace mucociliar, favorecer a hiperplasia também das adenoides e dos cornetos, né? Eu tinha uma preceptora na residência que falava que o pulmão começa no nariz, né? E é isso mesmo. Se a gente não trata, né, uma infecção, uma inflamação nasal, isso vai reverberar no paciente que já tem um grau de atopia, isso vai reverberar na questão pulmonar, né? E aí, então, por essa série de fatores patogênicos, a gente vai ter o desenvolvimento pulmonar prejudicado, certo? E aí, então, a gente entra no outro ponto importante, que é a correlação ao tabagismo ativo na faixa etária da adolescência, né? Os adolescentes, nós sabemos, são os mais susceptíveis ao tabagismo. Eles podem ser susceptíveis ao tabagismo passivo, mas também ao ativo. Por quê? Porque eles estão nessa faixa etária que tem uma curiosidade por experimentar novas sensações, né? Uma necessidade de afirmar no meio onde vivem, pelas relações sociais, uso concomitante com o álcool, que favorece a iniciação ao tabagismo, né? E, além disso, a gente tem uma série de propagandas de cigarro. A gente já tem uma legislação, principalmente aqui no Brasil, né, que a gente não pode mais vincular a imagem, né, do cigarro, mas a gente sabe que isso na prática não é visto, não é tão realmente realizado, né? E a gente tem uma série de substâncias que podem ser consideradas como tabagismo. Desde os cigarros eletrônicos, que cada vez mais isso tem ficado muito presente, isso me preocupa demais. Há pouco tempo eu tive em contato com algumas pessoas que estavam fumando, e aí elas me falaram assim, cigarro eletrônico, né? E elas me falaram assim, Mari, mas é só um cigarro, é só um vapor. Gente, é só um vapor, né? Mas é um vapor com substâncias. E essas substâncias vão gerar, com certeza, né? Um dano a essa mucosa respiratória. E a longo prazo, principalmente para quem é asmático, isso vai ter repercussão, né? Se fosse vapor de água, a gente faria nebulização, né? Colocaria uma água lá e fazia uma nebulização. Mas não é isso que a gente está falando aqui, né? Além disso, a gente tem uma série de cigarros comuns mesmo, com cheiros, com sabores, que geram um atraente importante. E tem outras substâncias também que funcionam como, né, entram aí na questão do tabagismo, narguilé e outras tantos aí que são atraentes para os adolescentes e os adultos jovens também, né? Bom, e aí que eu acho que vale muito a pena a gente falar, então, de tabagismo ativo na adolescência, sobretudo nos adolescentes que são asmáticos, né? É porque as altas taxas de exposição à fumaça vão gerar mais sintomatologia diurna, e noturna, por conta dessa série de fatores patogênicos que eu já expliquei para vocês, e isso vai repercutir no descontrole da asma. Se eu tenho descontrole da asma, eu vou ter piora da qualidade de vida. E aí eu trago para vocês uma tabelinha muito importante que nós usamos, né? Que é sempre trazida pelo Gina, que eu imagino que seja do conhecimento de todos vocês, que é o principal, né? O principal guideline que nós usamos, na verdade, a principal iniciativa que nós, pneumologistas, pediatras, usamos para fazer o acompanhamento, manejo, controle da asma. E a gente sempre pergunta 4 perguntinhas: se eu estou tendo sintomas diurnos, se eu estou tendo sintomas noturnos, se eu fiz uso de salbutamol nas últimas 4 semanas, né, no último mês, e se eu estou tendo limitação de alguma atividade física, né? E basicamente, se eu estou tendo altas taxas de exposição à fumaça, provavelmente uma dessas perguntas ela não vai, ela vai ser respondida como sim, e eu vou ter uma piora do controle dessa asma. Então, em vez de uma asma bem controlada, eu vou ter uma asma parcialmente controlada ou uma asma não controlada. E isso vai repercutir em maior uso de corticoides inalatórios, né? Então, não tem jeito. Se eu tenho uma doença não controlada, com uma espirometria que me mostra que tem uma doença com uma obstrução ali leve a moderada, ou às vezes até moderada grave, né? Com uma broncodilatação positiva, isso vai fazer com que a agente médico vá aumentar a dose de corticoides inalatórios. E aí a gente vai passar de step 2 para step 3, né? Para step 4. E às vezes a gente vai estar diante de pacientes com asma grave, step 4, step 5, que tem limitação de atividade física, tem sintomas diurnos, sem sintomas noturnos e que mantém tabagismo. Eu tenho um ou outro paciente no ambulatório que, assim, a gente vem fazendo seja tabagismo ativo ou outro tabagismo passivo, né, gente? Que a gente vem fazendo uma construção, né, do tanto que isso repercute no controle dos sintomas e pior, eu aumento, então, essas doses de medicação. E aí, não tem jeito, né? Essa é a tabelinha do Gina que eu trouxe para vocês, é a última do Gina 2021, mas não tem jeito, né? À medida que a gente vai subindo os steps, né? Ou seja, a gente está tendo uma asma não controlada e por isso a gente está classificando esse paciente numa asma moderada ou grave, e isso exige mais medicações. Se eu estou usando mais doses, né, de medicações, seja corticoides inalatórios ou corticoides orais, eu vou ter uma repercussão em relação a isso. Então, eu vou ter mais efeitos colaterais dessas medicações. E isso, como que isso vai manifestar na nossa faixa etária, né? Da pediátrica e envolvendo inclusive os adolescentes. Uma das primeiras coisas que a gente vê é a alteração na velocidade de crescimento. Gente, é muito nítido. Esses meninos vão usando tanto corticoide que a gente vê uma curva, uma velocidade de crescimento praticamente paralisada. Além disso, a gente pode ter supressão adrenal por essas altas doses. A gente pode favorecer a imunossupressão, dependendo se eu estou usando corticoide oral aí contínuo. E isso pode repercutir, às vezes, até em fratura de cabeça de fêmur diante dessas altas doses. Então, realmente, a gente está tratando de um fator de risco importante no controle de asma que vai repercutir na gravidade no controle dessa asma, certo? Bom, e outra coisa que é importante, que a gente tem sempre que estar falando aqui, se eu estou exposta a altas taxas, né, de exposição à fumaça, se eu estou exposta a essa fumaça, seja ativamente ou passivamente, eu vou favorecer a perda de função pulmonar. E eu adoro esse trabalho, que é um trabalho, né, que mostra para a gente a exposição do tabaco desde a vida lá, né, do período gestacional até a adolescência com relação à função pulmonar. Esse trabalho foi publicado em 2018 num jornal maravilhoso que a gente adora, que é o European. E ele buscou mesmo avaliar as associações entre o tabagismo materno durante a gravidez, a exposição passiva durante a infância e o tabagismo na adolescência, por meio da avaliação da função pulmonar em pacientes com 16 anos. Então, eles fizeram realmente uma coorte por todo esse tempo, avaliando com foco da função pulmonar, né? E o que eles viram é que o tabagismo materno durante a gestação foi associado a um menor VF1-CVF. Para quem não conhece esse termo, é uma medida que a gente chama de índice de difenol. E quando ele está menor, provavelmente eu tenho um índice de doença obstrutiva, tá? Então, a gente viu que esse tabagismo materno estava associado ao menor índice de fenol nos filhos quando eles tinham 16 anos. Não foi observado nesse trabalho alteração da função pulmonar aos 16 anos relacionados ao tabagismo passivo durante a infância e adolescência nesse trabalho, né, gente? A gente tem outros trabalhos que já mostraram isso. E o tabagismo materno durante a gestação foi associado ao aumento da resistência da via aérea. Se eu tenho um aumento da resistência da via aérea, será que isso não vai favorecer um remodelamento dessas vias aéreas e eu tenho uma asma grave mais precoce, né? Bom, e o que eles acham que aconteceu, né? O que isso explicaria essas alterações? Primeiro que a passagem pela nicotina pela via transplacentária geraria uma lesão do epitélio mesenquimal alveolar, que é o que a gente já tinha discutido previamente aqui na aula, favorecendo, então, miofibroblastos em vias aéreas, tanto grandes quanto as pequenas vias aéreas, e isso caracterizando, então, uma doença pulmonar crônica, né? A longo prazo. Por quê? Porque aquela exposição ali, eu mudei a epigenética mesmo de todos, aquele ambiente, né, pulmonar, desde o período gestacional, certo? Uma coisa que eles viram, que eles questionaram, né, será que a associação entre o tabagismo materno durante a gestação tem alguma relação causal com o tabagismo na adolescência, né? E aí, uma coisa que eles trazem é que a exposição à nicotina durante o desenvolvimento cerebral, então eu estou falando de período gestacional, pode realmente influenciar a dependência da substância. Então, é uma coisa que lá no período gestacional pode repercutir nessas crianças de querer estar mais dependentes, né? De estar dependentes dessa substância da nicotina. E outro ponto, que é um impacto negativo sobre o crescimento pulmonar e sua predisposição à doença obstrutiva crônica, às infecções como pneumonias e os quadros de sibilâncias recorrentes. Bom, e por fim, né, o que o GINA traz para a gente como abordagem do tabagismo relacionada à asma? O GINA de 2021 mostra que o encorajamento de familiares a cessar o tabagismo, fornecendo aconselhamento e recursos de apoio, é um nível de evidência A para a gente melhorar, então, o controle da asma e, assim, melhorar o tratamento. O uso de doses mais elevadas de corticoides inalatórios em casos de asma não controlada, em pacientes mais expostos continuamente ao cigarro, é um nível de evidência B. Então, assim, eu acho que o que fica dessa mensagem é que é a prevenção, né? Quanto mais a gente falar, seja na atenção primária, na atenção secundária, quanto mais a gente expor o tanto que a gente tem que melhorar a exposição ao cigarro, isso com certeza vai ter uma repercussão melhor para esse paciente do que só a gente ir aumentando doses de medicação e estar sujeitos, né? Lógico que a gente vai ter que fazer isso com o paciente não controlado, mas eu falo do ponto de vista que a gente vai estar sujeito a efeitos colaterais de medicações. Certo, gente? Bom, é isso que eu quis trazer. O tempinho é curto, né, para a gente trazer um tema tão importante, mas eu acho que os principais pontos que eu queria abordar com vocês era isso mesmo. Meu e-mail está aí, meu Instagram profissional também, estou à disposição para quaisquer dúvidas. Obrigada.
Ei, doutora Mariana, perdão que o meu caiu aqui rapidinho.
Sem problemas.
Eu voltei, mas eu queria agradecer muito pela sua palestra. Eu não sei se teve alguma dúvida no chat, se as meninas puderem colocar. Tem, a da Juliana. Qual a melhor forma de incentivar a interrupção do tabagismo em uma família?
Bom, Juliana, seguinte, a primeira coisa que eu trago com esses pais, se são os pais tabagistas de crianças asmáticas, eu tento colocar a responsabilidade para eles mesmos. E aí o que eu falo com eles é o seguinte: primeira coisa, para eles pararem de fumar, vai ser bom para eles. Eles vão prevenir doenças em relação a eles. E depois, eles são responsáveis pela saúde do filho deles. Então, o que eu sempre tento encaminhar? Aqui em Belo Horizonte, por exemplo, no Hospital das Clínicas, a gente tem grupos de tabagismo, então ou na atenção primária também. Então, eu sempre tento encaminhar esses pais para esses grupos para que eles sejam referenciados e que a gente tenha uma rede de suporte para que eles consigam parar. Parar de fumar não é uma coisa fácil, né? É uma coisa difícil, que está associada, às vezes, com o comportamento, com o hábito de vida, e às vezes não é só o pai ou a mãe, às vezes tem outras pessoas que moram na casa que fumam. Então, assim, o que a gente tem que tentar fazer é tentar mostrar para essa família que a saúde de todo mundo ali, sobretudo daquele asmático, depende dessa mudança de comportamento. E para isso, então, eu tento usar a rede para tentar me ajudar a melhorar isso aí, certo?
Beleza, ótimo, né? Deixa eu ver se tem mais alguma pergunta. E os pais, vendo esse retardo de crescimento nos filhos, ficam mais incentivados a cessar o tabagismo?
Ficam. Quando a gente pega a curva de crescimento e a gente mostra para eles, fala assim, olha, gente, olha como é que está aqui a curva de crescimento. Seu menino estava dessa forma, mostrando, e basicamente agora a gente tem uma velocidade baixa, né? Por quê? Porque eu estou usando muita medicação e ele está tendo sempre exacerbação. Então, ele não parou de crescer por causa do cigarro, mas ele parou de crescer porque a asma dele está descontrolada e isso tem relação com o cigarro, né? Então, eles ficam, sim, mais sensíveis. Mas é um trabalho de formiguinha, não é uma coisa que de uma consulta para outra você consegue mudar, não. Mesmo porque você precisa de uma relação médico-paciente bem estabelecida com aquela família. E eu não consigo isso num encontro, 2 encontros. Então, é realmente um processo mesmo que demanda bastante mesmo.
E nada melhor do que mostrar com provas, né? Da importância,
Exatamente.
né?
E eles mesmos trazem isso para nós, né? Eles mesmos fazem. Ó, meu filho não controlou, mesmo com essa alta dose. E aí, uma coisa que eu sempre falo com eles é o seguinte: você acha que isso, só a gente passando remédio, eu ficar só passando remédio, isso vai mudar? Não vai mudar. Então, nós estamos jogando remédio fora, né? Eu brinco com eles isso. Porque se a gente ficar só usando remédio e não fizer controle ambiental, gente, seja com cigarro, com ácaros, né? Com cortina, tapete, fogão a lenha, que tem muito aqui no Brasil. Então, não é suficiente para o controle desses pacientes. Então, a gente tem que englobar tudo. Então, é isso que eu tento trazer para eles, sabe?
Entendi. Perfeito, tem que ser assim mesmo, né? De pouquinho em pouquinho. Deixa eu ver se tem mais alguma pergunta. Acredito que é isso mesmo. Doutora Mariana, eu queria agradecer demais pelo seu tempo e pela sua apresentação. Acho que contribuiu demais para o nosso evento e para o nosso crescimento pessoal também. Mais uma vez, muito obrigada. Fique à vontade para acompanhar o resto do evento, se você tiver e quiser também. E queria agradecer. Muito obrigada, viu?
Eu que agradeço, gente. Eu acho que esse tipo de evento é sempre bom para a gente poder discutir, né, medidas embasadas na literatura, para a gente fazer uma prática da medicina melhor, tá? Agradeço demais mesmo pelo convite. Um bom evento para vocês.
Obrigada. Tchauzinho. Então, gente, dando continuidade no nosso evento, a nossa próxima palestra será sobre GINA 2021, o que mudou, com a doutora Lívia Isabela. Ela é médica, pneumologista pediátrica, coordenadora médica da Unidade de Internação Pediátrica do Complexo Hospitalar de Urgência, a FEMIG. Ela já está aqui com a gente.
Oi.
Doutora Lívia, bom dia, tudo bem?
Bom dia, tudo jóia. Obrigada, viu, Júlia, pela oportunidade. Tá sendo muito bacana, né? Todas as apresentações estão excelentes, né? Vamos falar um pouquinho sobre o GINA agora, né?
Isso mesmo, pode ficar à vontade para começar essa apresentação e muito obrigada por estar aqui com a gente hoje.
Obrigada. A tela apareceu direitinho?
Tá aparecendo aqui, sim.
Ótimo. Então tá, gente, vou falar um pouquinho sobre o GINA 2021, o que mudou nesse ano. Então, o GINA, ele foi criado pela Organização Mundial de Saúde e pelo Instituto Nacional de Coração, Pulmão e Sangue em 1993. O GINA, igual a doutora Mariana falou anteriormente, ele é como se fosse o nosso guia, né, da pneumologia. A gente utiliza muito, segue muito as recomendações dele. Ele foi feito para aumentar a conscientização sobre a asma, melhorar a prevenção e gestão da asma por um esforço que é coordenado em todo o mundo. Então, ele é muito interessante, ele é muito baseado em evidências, né? O GINA ele é independente, financiado apenas pela venda e licenciamento dos seus relatórios. E essa estratégia global, né, que é baseada em evidências, ela pode ser adaptada para a saúde local. Então, a gente consegue adaptar o GINA para a nossa realidade local, por exemplo, aqui no Brasil e em vários outros países. Então, gente, o GINA vem com algumas perguntas sobre Covid-19 e asma. Então, vou trazer porque, ainda mais nesse contexto de pandemia, todo mundo ficou com muita dúvida e o GINA esclareceu algumas delas. Então, as pessoas com asma apresentam risco aumentado de Covid-19 ou Covid-19 grave? Então, segundo os estudos que o GINA utilizou, aparentemente não há um maior risco de adquirir Covid-19 e as revisões sistemáticas não mostraram um risco aumentado de Covid-19 grave nas pessoas com asma leve a moderada, bem controlada. Então, isso é importante, viu, gente? Então, aquela pessoa que tem asma, mas que a asma, né, está controlada. As pessoas com asma apresentam risco aumentado de morte relacionado à Covid-19? E aí entra novamente a questão da asma bem controlada. Nessas pessoas não tem o risco aumentado de morte relacionado à Covid-19. Entretanto, naquelas pessoas que ou tiveram que usar recentemente um corticoide oral ou precisou ser hospitalizado com uma asma grave, nessas pessoas o risco de morte por Covid-19 aumentou. Quais são as implicações para o gerenciamento? É importante manter, né, as medicações, manter um bom controle dos sintomas, reduzir o risco de exacerbações graves e minimizar a necessidade de corticoides sistêmicos. Ou seja, né, gente, controlar essa asma, ir ao médico, manter as medicações em dia, né? E isso tudo vai acabar influenciando. Houve mais exacerbações de asma durante a pandemia? Então, não, né? Em 2020, a gente viu que, na verdade, por exemplo, né, eu trabalho no hospital pediátrico, o hospital ficou bem mais tranquilo, né? A gente tinha muitos leitos vagos no CTI, pronto atendimento ficou vazio. Então, foi um ano, né, na pediatria que foi mais tranquilo, né? A gente teve menos circulação de vírus respiratórios, e isso pode ser explicado devido ao uso de máscaras, mais lavagem de mãos e o distanciamento social. Esse ano, né, com a flexibilização, né, com o retorno às aulas, acaba que a gente viu que o número de infecções respiratórias aumentaram. Não necessariamente pela Covid, mas pelos outros vírus que não estavam circulando anteriormente. Em relação aos medicamentos, né, continuar usando os medicamentos de asma já prescritos pelo médico, né, manter o tratamento usual, né, conforme o GINA. Lembrar sempre que o médico tem que deixar um plano de ação com o paciente. Então, se ele começa a ter algum sintoma, se ele tem alguma exacerbação, ele tem que ter por escrito o que ele vai fazer. E a recomendação que o GINA dá é em relação a nebulizadores, que para tentar evitar, sempre que possível, por causa de disseminação, propagação de vírus por aerossol, e tentar usar um inalador dosimetrado pressurizado através do espaçador. É diferente em relação ao uso de medicamentos. Em relação ao controle de infecção, o GINA orienta, né, evitar de fazer espirometria naquele paciente que ou está com Covid-19, né, confirmado, ou suspeito, e também se você tiver uma grande transmissão comunitária de Covid-19, né, porque é um procedimento que libera muito aerossol. E se você for, né, fazer uma intubação orotraqueal, colocar um paciente em VNI, PAP, que são todos procedimentos que geram aerossol, lembrar sempre de seguir os procedimentos estritos de controle, usar o EPI adequado, né, ou no ambiente adequado e com os materiais adequados. Em relação às vacinas, as vacinas foram estudadas em pessoas com asma e, inclusive, estão sendo utilizadas em todo o mundo nas pessoas com asma. E ainda estão surgindo muitas evidências, né, de como que vai ser. Isso só com o tempo para a gente saber, né, porque é uma doença muito nova, as vacinas são muito novas. Mas hoje, Gina recomenda que as pessoas com asma recebam vacinação contra a Covid-19. É importante ressaltar que não deve administrar no mesmo dia do imunobiológico, então vacina imunobiológica em dias diferentes. E as pessoas com asma devem continuar recebendo a vacinação anual contra a influenza. A asma, né, gente, é uma doença crônica, não transmissível, mais comum, né? Em 2019, ela afetou mais de 260 milhões de pessoas. É uma doença com sintomas respiratórios variáveis, então você vai ter a sibilância, você vai ter opressão torácica, dispneia, e isso, né, é associado a uma inflamação das vias aéreas. E tem alguns momentos que, né, aquele paciente que tem asma vai ter exacerbações, que são aquele momento que você tem uma piora, né, naquela obstrução ao fluxo aéreo, e com isso você vai ter um aumento dos sintomas. A maior parte, tanto da morbidade quanto da mortalidade associada à asma, é evitável com tratamento adequado, acompanhamento adequado com o médico. O GINA sempre vai trazer, né, esse ciclo aí, né, que são perguntas, né, e que a gente deve fazer para o paciente em toda consulta médica. Então, toda consulta médica, eu vou revisar com o meu paciente os sintomas que ele está tendo, se ele teve alguma exacerbação, se ele tem algum efeito colateral com a medicação que ele está usando, fazer a função pulmonar, né, que é a espirometria, e ver como que está a questão da satisfação do paciente com esse tratamento, se ele acha que está tendo alguma melhora, se ele acha que não está funcionando. É importante sempre também avaliar, ou seja, esse diagnóstico está correto? Tem algum fator de risco que eu posso modificar? Por exemplo, ele é tabagista, ou então ele é um tabagista passivo, ele tem alguma outra comorbidade? Como é que está a questão da técnica inalatória? Está usando a medicação de forma correta, né? E também sempre ajustar. Então, eu vou ajustar ali a medicação. Então, se ele está bem controlado, eu posso fazer um step down. Se eu vejo que ele não está controlado, eu posso fazer um step up, né? E aumentar o nível das medicações. E sempre também ver o que o paciente está entendendo da doença dele, né? De como que ele deve agir perante uma exacerbação. Então, gente, o tratamento da asma não funciona em one size fits all, ou seja, não tem uma receita de bolo que eu vou seguir para todos os meus pacientes, né? Que todo para uma roupa para vestir uma cobra, uma tartaruga, um elefante, né? Cada um vai ter um tamanho, a mesma coisa do paciente. Cada paciente, né, vai precisar de um tipo de tratamento de acompanhamento. Em 2019, a gente teve uma mudança muito importante no GINA, uma mudança chave, no qual a gente teve uma mudança no Step 1, ou seja, na etapa 1, não é recomendado mais usar só o SABA, que é o beta-2 agonista de curta duração. Então, só mostrando aqui, né, os steps, que até a doutora Mariana até mostrou também. Então, a gente vai dividir, né, segundo o GINA, entre aqueles pacientes que estão usando a mesma medicação para controle e para alívio, né, em caso de sintomas, né, medicação de resgate, e aqueles pacientes que usam medicações diferentes, ou seja, eles vão usar uma medicação para controle e uma medicação para alívio diferentes. Naqueles que usam a mesma medicação, tanto para controle quanto para alívio, né? Quando ele começar com algum sintoma, né? Ele vai usar o corticoide inalatório mais o formoterol, né? De acordo com a necessidade, as needed, né? O formoterol foi escolhido porque ele tem um início de ação mais rápido, por volta ali de 5 a 10 minutos, diferente dos outros beta-2 de longa. Então, né, eu vou usar o corticoide junto com o formoterol, né, no step 1, step 2, e também como alívio nos outros steps, então step 3, né, step 4, step 5. E naquele paciente que usa outra medicação de alívio, né, uma medicação diferente da manutenção da medicação de controle, como alívio, eu vou usar o SABA, né, que é o beta-2 agonista de curta duração. Outra mudança no GINA 2021 foi a questão do conceito da asma leve, que a definição atual é aquela que pode ser controlada apenas com medicação de alívio ou com corticoide inalatório em baixa dosagem. E o GINA não distingue entre a asma intermitente e aquela leve persistente. E o que acontece? Foi visto que aqueles pacientes que têm essa asma intermitente, eles ainda estão em risco de exacerbação grave. Então, foi por isso que teve essa modificação lá no GINA 2019, né? De já começar com um corticoide inalatório, já no step 1, né? Para evitar, né, esse risco de exacerbações graves. E o GINA está planejando revisar esse conceito, né, de asma leve durante esse ano de 2021 para sair no GINA 2022. A asma grave, o conceito não está relacionado às etapas do GINA, porque a gente vê que tem uma mudança ao longo do tempo, né, desses steps. E a asma grave é aquela asma que ela permanece não controlada, mesmo você usando um tratamento otimizado com alta dose daquele corticoide inalatório, mais o LABA, que é aquele beta-agonista de longa duração. Então, eu ia até trazer o vídeo, só que eu fiquei com medo do vídeo travar, mas esse episódio do House, que tem uma paciente que chega lá e fala assim, olha, minha asma não está controlando. Essa medicação que o médico me passou, ela não está servindo. E aí o House pergunta para ela assim, você pode me explicar como que você está usando a sua bombinha? E ela fica até brava, fala assim, nossa, não é possível, você acha que eu sou idiota, que eu não sei usar a bombinha? E aí, na hora que ele pede, ela está usando a bombinha como se fosse um perfume, está usando no pescoço. Então, gente, é muito importante em toda consulta, você olhar como é que está a técnica inalatória, se a pessoa está usando de forma correta, né? Se for espaçador, se a família sabe usar o espaçador, porque antes de você subir, né, fazer um step down e aumentando ali a dose, né, de corticoide inalatório, né, associando outras medicações, sempre ver se o tratamento, né, está sendo feito da forma correta, tá, gente? Isso aí levar para a vida, isso é muito importante. Em relação às crianças de 6 a 11 anos, a recomendação do GINA é usar o corticoide inalatório, né, já no step 1, em dose baixa e associado com o SABA, né, desde do step 1, né, que antes a gente não usava, a gente usava o SABA sozinho, e aqui a gente não usa aquela associação com o LABA, tá? Então, essa é a diferença. E nas crianças menores de 5 anos, no step 1, a gente vai usar o SABA, tá? O SABA isoladamente, tá? E lembrar que sempre que você tem uma criança menor de 5 anos, que não está tendo melhora com o tratamento, lembrar de referenciar ela para um especialista. Nos próximos GINAs, o que eles definiram, né, como temas a serem abordados? Essa definição da asma leve, há evidência sobre imunoterapia, né, com alérgeno subcutâneo e alérgeno sublingual, e também as recomendações sobre asma e Covid-19 ainda vão ser atualizadas, né, durante esse ano, para o ano que vem eles trazerem as novidades, né, os estudos que surgirem. Então é isso, gente, muito obrigada. Esse é meu e-mail. Quem tiver qualquer dúvida pode me enviar, tá bom?
Pode ir. Muito obrigada, doutora Lívia, pela palestra. Foi incrível, contribuiu demais para o nosso evento. E eu queria só ver se tem alguma dúvida no chat para a gente Só encerrar. Eu não consigo, acredito que não deva ter nenhuma dúvida. Mas muito obrigada pela sua palestra, pelo que você disse. É muito importante a gente sempre se manter atualizado, né? Principalmente quando acontece uma pandemia que envolve muito essa parte respiratória. Então, a gente realmente é necessário a gente se manter por dentro das novidades, das mudanças, né?
Isso mesmo, né? E o Gina, todo ano tem uma edição nova, né? Então, sempre acompanhar que todo ano tem alguma novidade, né?
Exatamente. Muito obrigada, doutora Lívia.
Eu
Bom
que
dia para
agradeço.
você e fique à vontade agora para permanecer, se você quiser. E amanhã a gente tem mais também. Muito
Tá bom, muito
obrigada.
obrigada, viu?
Tchau. E, pessoal, continuando agora, teremos agora as nossas apresentações orais. E depois teremos o nosso sorteio. Então, continuem aí, firmes e fortes, que daqui a pouquinho a gente vai ter sorteio. Vamos iniciar as apresentações e depois a gente faz o sorteio. Podemos colocar aqui. Isso. Beleza. Oi, gente, perdão, a gente tá tendo umas questões. Eu acredito que rapidinho a gente já vai resolver. Só uns instantes, por favor. O que foi que tá pensativa? O que foi que tá pensativa, minha? Gente, ainda continuamos com uns probleminhas técnicos. A gente tá resolvendo aqui e já voltamos.
Good morning, my name is Maria Clara and I will present our expanded summary, and it's about histological and physiological changes in the airway due to asthma and was a literature review. Me, Arthur, Isabella, and Pedro wrote this work. We are all in first year of medical school in PUC, and our mentor is Style Bar. She's our human anatomy professor. So asthma is a lower airway pathology characterized by bronchial inflammation and affects 300 million people worldwide and represents 250,000 cases of death per year. So a better pathophysiological understanding of asthma is necessary to understand how this disease works, like the mechanism and its histophysiological consequences. So as a methodology, we executed a literature review based on 16 articles in the PubMed and CL platforms, and a compilation of the main findings of these articles was created. And our objective was to show the main change resulting from asthma in histological strata of the airways. So asthma is a bronchial inflammation resulting from external and internal stimuli, and a series of physical changes that lead to this inflammatory process were evidenced from the 16 articles studied, like changes in the respiratory epithelium, hyperplasia and hypertrophy of submucosal glands, vascular change, degradation and fragmentation of elastic fibers, and smooth muscle hypertrophy. So, and we'll talk about all of them now. The respiratory epithelium suffer a reduction in ciliated cells, desquamating this tissue, making it fragile and allowing the entry of antigens in the occlusion zones. When we have bronchoconstriction and bronchospasms, epithelial cells are subjected to a compressive force, resulting in mechanical stimulation, activating them to produce TGF-beta, stimulating cells of the immune system to act there. Submucosal glands. With asthma, we can lead to hyperplasia and hypertrophy, contributing to excessive production of mucus. Also, ectasia of glandular ducts can occur, in which the presence of mucus in the lumen can increase resistance during bronchial smooth muscle contraction, so that the muscle has to do more force to contract, causing smooth muscle thickening. The edema is favored as a consequence of bronchial microcirculation strovization, and the increasing mucus thickness leads to a decrease in caliber internal weight, being an important factor in airway flow obstruction. When we talk about elastic fibers, we have two possible mechanisms of injury in asthma: the action of proteases and elastases released by inflammatory cells, and mechanical rigor. The enzymes have the ability to degrade elastin, and mechanical rigor contributes to its ruptures. So when elastin is degraded, elastin recoil decrease, which is the energy released from the deformation suffered by elastin fibers, causing dyspnea. In respect of smooth muscle, its hypertrophy and its hyperplasia can be caused by inflammatory agents, contractile antagonists, cytosines, and growth factors listed with asthma. The contraction of the bronchial smooth muscle is stimulated, resulting in bronchial narrowing. Airway smooth muscle cells in asthmatic patients can multiply twice as much as expected, characterized by muscle hypertrophy. And the increase in number of myocytes results in overabundant narrowing of bronchial lumen. Here we have two fingers, and in both we can observe changes in respiratory muscle and epithelium. Moreover, we can see a decrease in the caliber of internal airway. So as a conclusion, we observed that the reviewed studies converge to the alteration and remodeling of several histological strata of the airways and present a complex histophysiological dynamic that determines the clinical scenario of asthma. So here we have the reference of our expanded summary, and thank you so much for your attention.
Ei, gente, então essa foi uma das nossas primeiras apresentações sobre da apresentação oral de trabalho, que foi enviado o vídeo, que nem vocês assistiram. A gente vai passar uma outra apresentação oral também, em formato de vídeo, que a gente vai colocar em alguns momentos. Depois teremos nosso aguardado sorteio. Espero que todos estejam animados. Temos também outros sorteios acontecendo. Olhem lá no Instagram do iBinsac, o primeiro Binsac. E olhem lá no nosso Instagram, tem outros sorteios que vão acontecer amanhã. Temos sorteio de jalecos e hoje vamos ter o sorteio da Saná, que vão ser sorteados 2 livros e que a gente vai sortear para vocês. Já vamos colocar aqui a apresentação oral. Espero que vocês estejam gostando do nosso evento. É muito importante para nós a participação de todos e que vocês estejam entendendo por ser uma apresentação, um evento internacional com apresentações em inglês. É muito importante para o nosso currículo e para o nosso desenvolvimento também. Espero que vocês estejam aproveitando cada momento e não deixem de participar dos sorteios. Se vocês não estavam sabendo, vocês podem participar, confiram lá no Instagram, olhem lá, amanhã a gente vai ter outros sorteios também, não deixem de participar, vão ser muito legais, a gente até preparou isso com muito carinho, e vão lá, deixe de participar, ainda dá tempo de participar desse da Sanar, que vai acontecer daqui a pouco, depois da apresentação, então corram lá, não percam essa oportunidade não. Beleza, a gente vai colocar aqui a apresentação.
Sleep apnea syndrome as an etiology of atrial fibrillation. It was written by myself, Arthur Nederissa, together with Isabela Carvalho, Maria Clara Andrade, Pedro Marius, and the tutor Hugo Nederissa, which is a cardiac surgeon at Santa Casa Hospital, Belo Horizonte, Minas Gerais. To understand the importance of this case report, we have to link the obstructive sleep apnea syndrome, which is a breathing disorder, together with atrial fibrillation, which is a heart disorder. So, over the past few years, there has been growing evidence that one OSAS leads to AF. So our patient is a male, 65 years old, hypertensive, former smoker, alcoholic, whose BMI is 32.6, and he goes to the ER department with complaints of palpitations. At the physical examination, his heart rate was above average. He had irregular pulses, and also his blood pressure was normal. It was requested a 24-hour Holter, which diagnosed a paroxysmal atrial fibrillation, mainly at night. It was also requested a transthoracic echocardiogram with no significant alterations, and also blood tests didn't show any significant alterations. So the procedures were to abstain from alcohol consumption and also the administration of bisoprolol, amiodarone, and warfarin. And after 3 months, the patient showed partial improvement, but the maintenance of episodes of paroxysmal atrial fibrillation. Executed a polysomnograph study, there has been the confirmation of OSAS. So the procedure here was to use a CPAP during nighttime sleep, and for the patient to go a weight loss program, as well as a lifestyle habit changes. After 1 month, he showed no further episodes of AT. He had his medication discontinued, and he showed improvement on his OSAS condition. So how does obstructive sleep apnea syndrome causes atrial fibrillation? The answer lies in the pressure swings of the respiratory cycle, which can be seen in this graph. Here we have a cycle of hyperapnea, apnea, also hypocapnia, and hypercapnia. And this forced inspiration against the occluded pharynx is accompanied by a negative pressure in the pleural space, increasing the pulmonary arterial pressure and overloading the right chambers of the heart. As a consequence, the right atrium dilates and pushes the interatrial septum, diminishing the left atrium and increasing the pressure inside it. Hence, there is a myocardial dilation and structural changes causing atrial fibrillation. So getting back to our patient, we see that the medical team diagnosed very well the atrial fibrillation through the above average heart rate, and also irregular pulses. Probably in the echocardiogram, they didn't see any P wave, which is the best sign for the atrial fibrillation condition. And the 24-hour Holter confirmed atrial fibrillation, mainly at night. At first, the medical team didn't suspect obstructive sleep apnea as the cause of atrial fibrillation, so they did the usual procedure, which is abstain the patient from alcohol consumption and administrate bisoprolol, which is a beta blocker, amiodarone, which is antiarrhythmic, and varfarine, which is a blood thinner. After 3 months with the maintenance of AF, they finally suspect of OSAS, which was diagnosed by a polysomnograph study. With that, they used CPAP during nighttime sleep, which helped him to have no further episodes of AF. So the case depicts very well the association between OSAS causing AF, and this association is not usually suspected at first. So when patients with AF present risk factors of OSAS, this association should always be kept in mind.
Então, essa foi mais uma da nossa apresentação de hoje. Muito feliz dos que mandaram os trabalhos e apresentaram aqui. Então, para a gente dar continuidade ao nosso dia de evento, vamos fazer aqui o sorteio. Eu vou compartilhar minha tela aqui e deixa eu ver, peraí. Que aí vocês podem conferir certinho. Eu vou... Só conferir certinho, tá? Tudo certinho? Aqui a gente está usando o site do sorteador e a gente vai fazer, que nem eu falei, o primeiro sorteio da Saná. Vou só dar recarregar, ver se alguém comentou mais alguma coisa para a gente já fazer. Como são 2 livros, serão 2 pessoas sorteadas. Então, vamos fazer o primeiro sorteio. Deixa eu carregar aqui. Aqui. Esse sorteio. Então, 11h27, a gente já conseguiu 128 comentários. Então, vou carregar os comentários. Ó, vai ser um ganhador, depois eu sorteio o outro. Tem aqui os comentários de todo mundo. Vamos ver quem. E o primeiro sorteado foi o @berger. Por favor, entrar em contato com a gente no... Pode tirar print aqui, deixar um tempinho aqui para vocês verem. Depois a gente vai conferir certinho as regras do post do Instagram. E, por favor, entre em contato com a gente, né? Manda um direct pelo nosso Instagram. Que bom! Entre em contato com a gente e aí pra gente acertar certinho. E aí esse foi o primeiro livro, que foi do, se não me engano, é o Yellow Book, né, oferecido pela Sanar. Agora eu vou sortear um outro ganhador. Eu vou voltar do início para ficar mais justo. Eu acho que aqui dá também se eu selecionar de novo. Selecionar outro. E o outro ganhador foi a Lohana Jarduli. Depois entre em contato também com a gente pelo parabéns, ganhou o outro livro escrito que está na descrição do post do Instagram. Entre em contato com a gente também para a gente poder acertar. Até hoje, por favor, que a gente, qualquer coisa, vê também outros sorteados. Então, eu vou parar de compartilhar aqui. Foram esses os ganhadores. Parabéns aos ganhadores. Espero que tenham ficado muito felizes. Stop sharing. E amanhã teremos mais sorteios e mais apresentações e mais eventos. Por hoje, gente, muito obrigada pela atenção, por vocês estarem aqui, comparecerem. Muito obrigada de verdade por participarem. Que nem eu falei, amanhã a gente vai ter mais palestras, mais apresentações e mais sorteios. Não deixem de perder, amanhã, horário 8h15 no horário de Brasília. Então, vejo vocês. Até lá e bom dia para vocês. Tchauzinho.